lupus right in the areas where he's now having this erosive sort of ulcerative change, okay? So I think patient has a history of lupus, has a history of discoid lupus. This is erosive discoid lupus, right? We just showed you a picture. Looks pretty similar, erosive discoid lupus. But actually, when we biopsied this patient, and if you can see here, this is something called a multinucleated keratinocyte. This patient actually has herpes within his discoid lupus. Okay? And so this is called isotopic infection, or where you have one disease, a different disease, affecting the area that a previous completely separate entity existed in. And so in this case, this is secondary infection by herpes, like from a cold sore into this patient's discoid lupus. Similarly, here's a patient who has discoid lupus. You can see now we know hypo or depigmentation, hyperpigmentation in the background, and very thick scale. Looks like hypertrophic DLE, right? But this is scabies, okay? So this patient actually had isotopic scabies involving her discoid lupus. And so whenever a lesion of discoid lupus that previously looked like one thing starts to change, you really want to make sure that what you're dealing with is not either some sort of sinister process or infection occurring within the lesion of discoid lupus. Patients who develop squamous cell carcinoma in their DLE actually do more poorly than persons who have spontaneous squamous cell carcinoma. So this was the patient that I showed you a little bit earlier, and you notice that he has discoid lupus, one lesion behind the ear and one lesion on the chest. That's all he has, okay? So I have a question for the audience. The previously shown patient, and you saw that he had one behind the ear, one on the chest. How do we best classify this patient? Is this multilesional DLE? Is it polylesional DLE? He really only has two. Is it extracephalic DLE, so it's not involving the head? Or is it generalized DLE? All right, multilesional, early start. Okay, some generalized DLE catching up, polylesional. I agree, there are not that many. There are not that many of them. All right, so we have polylesional DLE kind of leading the pack, and then multilesional, generalized, and nobody for the extracephalic. I like the extracephalic, but I guess it's not a favorite. It's not a favorite. We're not going to coin that term. So actually, this is generalized DLE. So by definition, once you have DLE below the neck, it's considered generalized. And the importance of this is leading us into the next part of the DLE story. Who has DLE and is at increased risk for having internal involvement or systemic involvement? And one of the features is the clinical presentation. So if you have DLE below the neck, generalized DLE, you are at increased risk for developing systemic lupus. And people have looked at all sorts of parameters, so I'm just going to guide you through some that are kind of generally accepted. So generalized discoid lupus, which as I said is discoid lupus below the neck. ANA positivity, and probably any ANA positivity, but particularly, relatively high titer ANA, so like 1 in 320. Persons who are more richly pigmented, so skin of color patients are at higher risk for developing internal lupus if they have DLE. Arthralgia or arthritis, so any patient with discoid lupus and joint pain is at high risk for SLE. Leukopenia, so if the white cell count is abnormally low, then these patients are also at risk. Anemia, if you take out your dermatoscope, which I know all the dermatologists have, but maybe some of the rheumatologists also have, and you see dilated blood vessels or nail fold telangiectasia, this also increases the risk. And young age of onset. So if you have your discoid lupus before the age of 25, you are at increased risk for developing systemic lupus. Is this DLE? Well, kind of, right? Let's look at the question. Is this DLE? Is it vitiligo? Post-traumatic scarring? Lupus profundus, or lupus vulgaris? All right, lupus profundus, often an early start, and lupus vulgaris coming in, post-traumatic scarring, always a thought, right? Lots of things look similar. Vitiligo, some persons, yes. All right, well, I think the majority have it with this one. So this is actually lupus profundus or lupus panniculitis. Slightly different, and I'll explain how. And I'll explain why as well. But before we look at the image again, just to remind us where lupus panniculitis sort of falls. So it falls kind of in between. So patients who have lupus panniculitis very often have skin predominant disease, but a subset of them will actually have systemic disease. And we'll look at the percentages in a second. So it's it's less common than discoid lupus. It's really characterized by inflammation of the fat lobules. So there's inflammation down deep within the skin in the fat. Up to half of persons with lupus panniculitis will meet the criteria for SLE, but they often have a milder clinical course, just like DLE patients. And so most patients do not have the inflammation isolated to the fat. If all of the inflammation is in the fat, then you call it lupus panniculitis. But if they have overlying DLE, like we saw in our patient, then we call it lupus profundus. And it's just kind of semantics, but important to know. So for example, in this patient, this lesion here, you can see there's depigmentation and a surrounding hyperpigmentation, classic DLE, but also notice that there's atrophy. There's like a dip in this patient's upper limb, and that's classic to how lupus panniculitis or lupus profundus presents. In addition to the inflammation at top, because of the inflammation in the fat, they lose that fat, and it's called lipoatrophy, and so these patients end up with these sinks in the skin. And it can be with overlying DLE, or here on the breast, you can see there's depression, but no overlying DLE. So this is a lesion of lupus panniculitis. This is a lesion of lupus profundus. It likes to affect the fat-rich areas because it's a fat inflammatory process, and so it likes areas like the thigh, it likes the buttocks, and sometimes it's quite inflammatory, as we see here. Okay? The face is also a common area. So, lupus panniculitis is easy. Not so fast. So, what about this patient who has, okay, yes. So what about this patient who has what looks identical to lupus panniculitis? So depressions in the thigh, patient has hyperpigmentation, looks like DLE overlying it a little bit, but you look at her upper back and you see violaceous discoloration. This is a Schall sign, and you see Gottron papules, so these papules overlying the knuckles. Well, this patient actually has panniculitis associated with dermatomyositis, which looks identical histologically and clinically to lupus panniculitis. So if we look at the features that can help us distinguish, a big mimicker of lupus panniculitis clinically, dermatomyositis. You cannot tell the difference. If you think you can tell the difference between lupus panniculitis clinically and dermatomyositis panniculitis, you're incorrect. The only way to tell the difference is if the patient has the classical hallmark signs of dermatomyositis as well. Unfortunately, most of them do have the hallmark signs, but occasionally, so like that's the Gottron's papule, the rash on the face, of the eyelids, but unfortunately, a subset of patients, the panniculitis is the first feature before all the other classical stuff of dermatomyositis. And so in these cases, you need to be careful and monitor these patients for a couple of years out just to make sure that what we classified as lupus panniculitis was really dermatomyositis in evolution. Okay, so just be a little bit careful. One helpful feature is that lipoatrophy, so that dip or that loss of the fat, is less common in dermatomyositis panniculitis compared with lupus panniculitis, and dermatopanniculitis tends to be more responsive to immunosuppression. So that's helpful. Now this patient has erythematous or red nodules on the thighs, classical area for lupus panniculitis, brand new rash, so the redness or the erythema is okay. Histology looks just like lupus panniculitis, but guess what? This patient is an elderly patient. So not to say elderly patients can't get lupus panniculitis, but this should raise your antennae. Is this something else? And I just want to bring your attention to the concept of subcutaneous panniculitis like T-cell lymphoma and its relationship to lupus panniculitis. These entities overlap histologically. Patients who have classic lupus panniculitis or lupus profundus 10 years ago can go on to develop subcutaneous panniculitis like T-cell lymphoma, and immunohistochemistry and sometimes clonality studies to pick up an abnormal T-cell clone is important for differentiating these. There are some features that help you to differentiate, but if you have a patient who doesn't fit clinically, is not responding to therapy, is kind of aggressive looking, always consider subcutaneous panniculitis like T-cell lymphoma. And while there are distinct entities, there is overlap, and there's an increased association in patients who have had a history of lupus panniculitis. So let's move now into tumid lupus. So tumid lupus falls all the way over here. This is lupus erythematous tumidus, or tumid lupus. And patients with tumid lupus do not typically have SLE, so it's very reassuring. Okay? However, it is the most photosensitive variant of cutaneous lupus, of chronic cutaneous lupus, that is, and the vast majority of persons only have skin disease. It tends to present with very juicy red lesions. I'll show you a picture in a second, and it likes the upper chest and the face. There is no interface dermatitis in these patients. So there's no interface dermatitis, which is a sort of classic lupus histology. So that's something to be aware of. So here you can see this juicy red. Oftentimes it takes on this ring shape. We call this an annular formation. So this sort of annular formation is classic for tumid lupus. There's usually no overlying scale or any surface change at all. And again, it loves this upper chest face area. This is a child who had tumid lupus, and you can see this sort of number 3 appearance. I thought this was kind of cool. And actually it's sort of, if you think about it, it's just these are incomplete rings. Okay, they're trying to form a ring. It just hasn't fully formed it yet. So I think we answered that question already, so I'm going to move on to the next set in the interest of time. So let's move on to subacute cutaneous lupus. So subacute cutaneous lupus falls kind of more in the middle. About half of patients will have systemic lupus, but it is, generally speaking, patients who have subacute cutaneous lupus, their systemic lupus, it's a little bit more aggressive than discoid lupus patients, but it's not as aggressive as patients who have acute cutaneous lupus, which we'll meet in a second. All right, so question, which of the following is true regarding SCLE? Up to a quarter of patients have drug-induced disease. Up to 50% of patients have associated SLE. Anti-Ro antibodies are greater than anti-La antibodies, or all of the above. Yeah, so I think all of the above, that is true. A quarter of patients have, yes. All right. So that's absolutely true. All of the above are true. And this is really important, particularly that first point. Up to a quarter of patients with subacute cutaneous lupus have drug-induced disease. And this can take 2 forms. It can be that the patient never had lupus and they took a drug that induces it. I'll go through a list with you in a second, and they develop it. But what's emerging is that patients who had pre-existing lupus, so you know they have lupus, but they've had chronic discoid lupus for years and years and years, all of a sudden their pattern of skin lupus changes and they develop subacute cutaneous lupus. Look for a drug cause, okay? And patients who develop drug-induced subacute cutaneous lupus, very often, if you figure out it's a drug, you stop the drug, it goes away. Not invariably, but most of the time. Okay, so it's relatively rare, about 8% of all cutaneous lupus. Ro positivity is the vast majority, but some patients do have La positivity or SSB. Up to half will meet the criteria for SLE, but only 10 to 15% of those who meet the criteria for SLE will actually have severe disease. Most patients have relatively mild disease with low white cell counts and maybe some arthralgias. And as I said, up to a quarter will have a drug trigger. All right, so what does it look like? It tends to look like rings, just like we saw for tumid lupus, but it tends to be a little bit more extensive, and very carefully, if you observe, there tends to be scale. There are different forms of this, and in Caucasian skin, it tends to be quite red like we see here. And this is the annular form or the ring type form, and this form looks a little bit more like psoriasis, so we call this the psoriasiform version of subacute cutaneous lupus. This is what it looks like in more richly pigmented skin. This is one of our patients, and you can still appreciate that sort of ring-like appearance, but it can be a little bit more hyperpigmented when it's active, but when it resolves, it tends to leave light-colored or hypopigmentation. These are some of the drugs that cause subacute cutaneous lupus, and I want to draw your attention to some drugs we use pretty commonly: terbinafine, thiazides, TNF-alpha inhibitors, and I'd like to highlight the proton pump inhibitors because a lot of patients who have SLE are on prednisone or are on chronic PPIs. And so if you have a patient, and by the way, the lag time can be like months to years, so if you have a patient on a PPI whose skin lupus has changed, so if they're on lansoprazole or omeprazole, whatever, and their skin lupus has changed and they've now developed subacute cutaneous lupus, think about switching out your PPI to an H2 antagonist or something like that, and see if their subacute cutaneous lupus gets better, okay? Same deal for Lamisil or terbinafine. So this is a patient who we saw who has subacute cutaneous lupus, nice annular lesions and more solid lesions, and guess what? This is within 2 weeks of starting terbinafine. It's out there, it exists, we just need to remember about it. All right, now the question is, which autoantibody is associated with drug-induced SCLE? Is it antihistone, anti-Rho, anti-La, or anti-dsDNA? And I think anti-Rho has the room. Well, no, antihistone, very good, because drug-induced lupus typically is histone positive. Very good. Okay, so histone is taking over from Rho. Well, guess what? Actually, it is anti-Rho. You're not wrong, those of you who chose histone, that drug-induced lupus typically is histone positive, but drug-induced subacute cutaneous lupus is unique in that it is antihistone negative and almost always Rho positive, just like endogenous SCLE. So it's a good time to talk about neonatal lupus. So neonatal lupus is uncommon, a manifestation in babies who are born to mothers who are Rho positive or La positive, or sometimes U1 RNP positive. Okay? And what happens is that the antibodies pass through the placenta and the baby manifests. But actually it's pretty rare, and only 2% of moms or babies born to moms who are Rho positive will actually manifest neonatal lupus. And the important thing here is that these patients can have cardiac disease, so they can have heart block, and up to 50% of them may need a pacemaker. Hepatobiliary disorders, they may have low platelets, and they may even have neurologic disease. And it kind of looks just like SCLE, but it tends to like the face and even the lateral side of the forehead. And in babies, you can also get this sort of raccoon eye change. So this is not a base of skull fracture. This is SCLE. This is not part of the SCLE. Okay, so finally we'll do acute cutaneous lupus. Okay, so acute cutaneous lupus belongs under SLE. Patients with acute lupus of the skin have SLE. If they don't have it today, they'll have it tomorrow. So ACLE is characterized by 3 eruptions. You have the malar rash or the butterfly rash that I think persons are pretty familiar with. We have generalized acute cutaneous lupus, which is the photosensitivity rash or the photosensitive eruption. And then let's not forget the toxic epidermal necrolysis or TEN-like acute cutaneous lupus. These patients often are dsDNA positive, though not invariably, and there's an association with nephritis. And what happens is that their acute lupus rash flares when their systemic disease is flaring. But when their systemic disease is quiet, the rash tends to go away. And it tends not to leave scars, but in richly pigmented persons, you can get a little bit of post-inflammatory change. So this is the typical butterfly rash, and you can see it here over the cheeks and the bridge of the nose. Looks like a butterfly, right? Very good. ACLE is easy. But what do we say? Not so fast, right? So my question is, and I hope it projects, is this ACLE? So we have the redness over the cheeks, over the nose. Is this ACLE or not? And the answer here is actually no. If you look very carefully, the redness actually is going into this patient's nasolabial fold. And this patient actually has dermatomyositis. Here's another example from our clinic, and you can see the purple erythema on the forehead, but also on the cheeks. But it's going into the nasolabial fold. Whereas for the butterfly rash of lupus, of acute cutaneous lupus, yes, it involves the same distribution, but there's clear sparing of the nasolabial fold. So dermato tends to involve the nasolabial fold, not always, but classically, and lupus tends to spare the nasolabial fold. And if you look at this higher power image, you can see the clear sparing documented here by the yellow arrow. So, ACLE or not? Nice nasolabial sparing, malar eruption. But this is not ACLE because there's a lot of scale, and if you look at this patient's skin texture, there are dips, they're subtle, but they're there. This is scarring. ACLE does not scar. This is discoid lupus in a malar pattern. Okay? So comparing to this patient who has some post-inflammatory hyperpigmentation, you do have nasolabial sparing, but there is no scarring, just post-inflammatory change. Okay? So not everything in a malar distribution is ACLE. Now, the acute photosensitive rash can involve the hands and look a lot like dermatomyositis, but if we compare it to dermatomyositis, in lupus, what you have is sparing over the knuckles, okay? So the joints are spared and the skin in between the joints are involved, as opposed to dermatomyositis, where you have involvement over the joints primarily. This looks like toxic epidermal necrolysis, the most feared manifestation of a drug reaction. So you take a drug, you lose all your skin, badness, okay? But you know, lupus can do the exact same thing or very similar. But one helpful feature is that you're losing skin in a malar distribution with sparing of the nasolabial fold, and you have this accentuation in that V of the neck, which is a very useful sign for autoimmune connective tissue disease that is responsive or triggered by sunlight or photosensitive disease. So it can look a lot like toxic epidermal necrolysis, but if you don't have a good drug trigger and you have a positive ANA, always consider that acute cutaneous lupus can give you a TEN-like presentation. This is a newer version of, or a newer finding in patients who have TEN-like lupus, and this is kind of annular eruption on the lips and tongue, okay? And this is being referred to as annular mucosal plaques of lupus erythematosus ample, a novel feature of Roux-en-La positive acute toxic epidermal necrolysis like lupus. And coming to the last slide here is the lab workup. Now, different people, and maybe Dr. McNish, who I'm so excited is home and will give us tons of tips in the next 1 minute or so. We may have different ways of working this up, so this I'm sharing with you is my approach to working up skin lupus in terms of labs. So I think all patients with skin lupus, mandatory, should have an ANA, plus or minus an ENA panel, if it is that you're thinking that, you know, this patient is very likely to be ANA positive. But I don't always do an ENA panel if the patient has 1 or 2 lesions of discoid lupus and a negative review of systems. CBC to look for any anemia or leukopenia, bun and creatinine to check for any kidney involvement, and a urinalysis. And you can consider doing this depending on how severe or how likely the patient is to have internal involvement. Then you'll do the ENA, double-stranded DNA. I tend to do the antiphospholipid antibody screens if I'm thinking this patient has systemic involvement. And if I'm suspicious that this patient has an overlap with either systemic sclerosis or myositis, dermatomyositis, I'll do the myositis panel and some scleroderma-specific antibodies. I tend to do a DCT for patients who have warning signs like generalized DLE, leukopenia, etc., just to check if there's autoimmune hemolytic anemia, and then I'll do a spot albumin creatinine ratio. But these I only do in select circumstances if I'm suspicious that there is systemic involvement. In terms of how often to repeat the test, for discoid lupus or other forms of chronic cutaneous lupus, I repeat it yearly if the patient is otherwise well. If there is one other warning sign, but the patient hasn't met criteria for lupus, then I'll repeat it in 3 to 6 months. If the review of systems changes, so the patient was perfectly well and now they have joint pain, even if they're not time to be screened yet, I will screen them again. SCLE, they have to get the basic panel, but reflex ENA, because occasionally Rho is cytoplasmic, and so the ANA is going to be negative, even though the patient is Rho positive. And so you really want to, for patients who have SCLE, because almost all of them are Rho positive, you want to reflexly do that ENA panel. And I screen these patients 3 monthly to 6 monthly if the initial screen is negative, which is pretty uncommon. And if the ANA is negative, make sure your lab is using indirect immunofluorescence rather than the ELISA, because it's much more sensitive. And you can get a titer, which is useful. And then ACLE needs the whole gamut. And so in terms of skin biopsy, important, but just bear in mind that patients do not always have to have interface dermatitis, which is kind of the catchword for the changes in autoimmune connective tissue disease. So tumid lupus, lupus paniculitis, Chilblain's lupus, and bullous SLE patients do not have interface dermatitis. And interface dermatitis we can see in drug reactions, we can see them in viral exanthems, lichen planus, etc. Mucin is not always present, because that's another kind of catchword. And so this is just very briefly to show you what an interface dermatitis can look like. So an interface dermatitis, this is normal skin. So this is epidermis, dermis. This is the junction or the interface, no holes. Interface dermatitis, epidermis, dermis, interface, lots of holes. This is an interface dermatitis. We're very fortunate to work where we work. We're very grateful for the opportunity to speak to you today. And I guess we'll take questions after Dr. Magnish's talk. Thank you.
Thank you very much, Dr. Ho, for that quite extensive talk on the skin manifestations of lupus. It's always great to listen to Dr. Ho talk. He's so interactive and he keeps the interest going. We will now have our second talk, which is going to be by Dr. Alicia McNish. She will be our keynote speaker. So Dr. McNeish was one of our first graduates from the DM dermatology program at UWI. So we're super, super proud of her. And she did extremely well in the program. We know that she will continue to soar super high. She literally just came back from Boston University, where she completed her fellowship in rheumatologic dermatology at Boston University, with a focus on the intersection of dermatologic and autoimmune disease. Her academic and clinical interests center on the advancing the management of complex autoimmune skin disorders and bridging innovative therapeutic approaches with practical patient care. She has just rejoined our team at the University Hospital of the West Indies, so we're super excited about that, as well as she's also in private practice. So, without further ado, we'll welcome Dr. Alicia McNeish to speak with us on current management of cutaneous lupus. By the way, sorry, I should have said this before. Any questions regarding any of the talks, I'm going to ask you to just put them in the chat for those who are on Zoom. Dr. McNeish.
Sorry, before I begin, I use the clicker, correct? Which clicker?
I had a different clicker.
Okay. Okay, perfect. Okay. All right, good morning, everyone, and thank you for being here. Cutaneous lupus, it bridges dermatology, rheumatology, internal medicine, and not only have we seen the full spectrum of how it can present and how severe things can be, but we're going to learn a little bit about, or update a little bit more about, management of cutaneous lupus. And this is particularly important because it will directly impact how a patient ends up turning out. I have no relevant disclosures. And these are the objectives for this morning. We are going to go through a structured approach to treatment, and we're going to go through general measures, topical therapies. We're going to go through systemic agents. We're going to highlight a little bit on sunscreen and photoprotection. We're going to talk about emerging drugs, clinical trials, and specific population, drug monitoring, and also lastly, we're going to touch on Raynaud's phenomenon as well, which is one of the associations of autoimmune diseases and lupus. So cutaneous lupus is broadly classified into these categories, and Dr. Ho just went through them very well. But why I'm also highlighting this again is that sometimes this directly influences the type of medication that you will use and how aggressive you will be in your treatment, right? So if you're having ulcerative disease, generalized disease, you may want to take a different approach versus if you have one single localized area. So broadly, the pathogenesis of cutaneous lupus involves immune dysregulation, type 1 interferon overproduction, keratinocyte apoptosis, and autoantibody deposition. UV exposure, smoking, drugs, and stressful conditions can also trigger lupus and upregulate that immune dysfunction. Oftentimes when the skin is flaring, you may find that the systemic portion of lupus is also flaring. So I apologize if you can't see everything on the screen, but this is the latest criteria for SLE. And basically what I wanted to show on this is that the skin really does deserve the respect that it gets, because in the criteria, you can see that just by adding up the points for skin, a patient can actually meet a significant portion of the criteria. So it deserves the respect that it gets, in addition to all of the other systemic findings that are present. So we also know that lupus has significant burden from a psychosocial point of view, and from that respect, it also deserves the respect that it gets, and again, to be very aggressive with management where necessary, because that directly can affect a patient's life, not just mortality. So we won't be diving into diagnosing lupus, but I would like to highlight something. I'd like to highlight one of the tools that we use to assess cutaneous lupus, and that's going to be the Cutaneous Lupus Erythematosus Activity and Severity Index. I'm going to refer to this as CLASI for a while. So the CLASI is divided into two major parts. That's CLASI A for activity and CLASI D for damage. And the CLASI A measures current active skin inflammation, and those could include factors such as erythema, scale, hypertrophy, mucous membrane involvement, acute hair loss, and non-scarring alopecia. CLASI D measures irreversible skin damage, which can include things like skin scarring, dyspigmentation, and scarring alopecia. And the clinical significance of this is that the CLASI assesses response to therapy. So at baseline, when you first meet the patient, you would do the CLASI, and you institute your management and intervention, and you want to repeat the CLASI at pretty much every visit to trend how the patient is responding to your therapy and intervention. The CLASI is also used in a number of clinical trials as well, where they use it to measure outcomes. So it's very important. A higher CLASI score can mean that a patient has become more active, and a lower CLASI score can indicate that you are on the right track with your management. Managing lupus will require a multidisciplinary approach, and this will be evident as we move through all of the slides and when we get to systemic portion especially. And the addition of the rheumatologic dermatology clinic is something I'm very passionate about, and I can't wait to really get that off of the ground to really bring this alive. Now, before or while thinking of systemic therapy, you also need to not neglect the other important aspects of management, which is what I call baseline principles. And that would include things like photoprotection, smoking cessation, vitamin D optimization, and your topical therapies as well. We're going to talk about photoprotection for a little bit. So UV light can augment the immune system in both a local and a systemic fashion. For autoimmune disease specifically, we know that UV light induces the release of inflammatory cytokines, including interleukin-1, interleukin-6, tumor necrosis factors, and other types of cytokines as well. And this can upregulate inflammation. The active sunscreen ingredients have been traditionally categorized into chemical sunscreens versus physical or mineral sunscreens. And basically why they have the name that it has is how it works. So your chemical sunscreens are ones that absorb UV radiation. Meanwhile, your physical or mineral sunscreens, they absorb and scatter UV radiation. And this will be very important when you're advising patients on what to use, and we'll get into that now. So this graph shows the relationship between sun protection factor, that's called the SPF, and the amount of UV radiation that is filtered by a sunscreen. The percentage of UV blockage approximately levels off about SPF 30, and this is why as dermatologists we always recommend no less than SPF 30. The concept is, if properly tested and applied, a product with an SPF of 30 would allow 30 times as much time in the sun with the same resultant level of erythema as without the product in a given individual by attenuating 96.7% of UV reaching the skin. what this means is the higher the sunscreen SPF is the more UV you're going to block in layman terms, right? So always remember to recommend no less than SPF 30 because that's really where the sweet spot is. In dermatology, different UV rays will contribute to different types of disease. But what we really care about is photosensitivity here. And as you can see, this table will summarize what's happening. So UVB, UVA, and visible light are all responsible for upregulating that immune dysfunction. Now, this table highlights 2 active ingredients in the mineral and physical sunscreen slots, and that's going to be titanium dioxide and zinc oxide. Those will be the most popular ingredients that you find in your physical sun blockers. I also want to highlight iron oxide. So iron oxide is pretty cool because it's going to block UVB, UVA, and visible light. Right? So you're getting more bang for your buck with a product that has iron oxide inside of it as well. And here's some great advice for patients. You can feel free to take a picture of it and mull it over. But the key things here are you need to use a broad spectrum SPF. That is one that's going to cover UVA and UVB, and we just mentioned honorably iron oxide. And also, you want to use a product, you also want to apply enough product. So for the body, traditionally it's 1 shot glass or 2 tablespoons, and for the face, 1 teaspoon is said to be enough. You also want to reapply throughout the day, especially if you're outside, and you want to pay attention to if the product is on after swimming because you need to reapply if you're sweating heavily or if you're engaging in water activities. Right? There are other general sun protection tips here. So paying attention to the clothing that you're wearing as well. Wearing a wide brimmed hat, and there's a specific definition for what a wide brim hat is. So you can pay notice to that. And also seeking shade. That's just a simple thing that anyone can do without even purchasing anything. All right, so patients dislike sunscreen. I think most patients that I counsel, like over 90% of patients, I have to really get them to buy into the sunscreen. And when I speak to them, I realize what the issue is. One, they don't understand why, and they don't know what products to buy. And this is a problem in skin of color, right? So for me, I would recommend these 2 brands. I have no affiliations with them, but I took this from a popular makeup blog site called Birdie, and this is a September 2025 issue where they actually published the top 10 sunscreens, and they highlighted these 2. Now, for the La Roche-Posay Anti-Helios Mineral Tinted Sunscreen, it comes in 4 shades. I've personally used it. I think it works very well. It's lightweight. And the key ingredients here, titanium oxide, zinc oxide, and iron oxide, right? And we just spoke about how important that was. It can be a little bit pricey at $38, but there are other options that you can cycle through. They may or may not have iron oxide, however. Now, these are also sunscreens for the body, and this isn't to be neglected, right? Because patients are not just gonna have disease on the face. What about the arms? What about the legs? So these are some great options here, and I want to just highlight the spray formulation. So the spray formulation, again, speaking with patients why they don't want to reapply, is because it's just too much work to rub it in. They're on the road, you're at work, like nobody wants to do that, right? But if you have a spray, you shake it, you spray, and you go. Very easy, right? So this is something I'd recommend for the body. Now, Moving on to other basic management principles, vitamin D. So optimizing vitamin D is going to be very important. There are some studies that have found a strong link between lower vitamin D levels and higher lupus activity, while others have not really found a clear association, but perhaps this is an area that really needs to be studied more. So the general advice is to optimize vitamin D levels. And also vitamin D is going to be important when you are monitoring for guidelines in osteoporosis as well. Smoking cessation, extremely important. This is a conversation you're going to have with the patient if they're a smoker. And you really need to drive these 3 points home, why they need to stop smoking, right? So one is that smoking directly increases the activity of lupus. Smoking interferes with the efficacy of medications such as hydroxychloroquine, so it can render it ineffective. And then 3, smokers with lupus are more likely to experience other related issues such as Raynaud's phenomenon. Now, topical corticosteroids are great for localized areas. However, you want to avoid strong topicals such as clobetasol, halobetazole, and betamethasone in your skin folds and on the face. And this is a table, if you can see it, indicating that what I just said, halobetazole, betamethasone, and clobetasol are in the higher potency ranges. Now, topical calcineurin inhibitors, they work in autoimmune diseases such as cutaneous lupus by inhibiting calcineurin, which is a very critical enzyme in activating T cells, and then thereby activating more lupus activity. Topical tacrolimus is what we have available here. It works excellently, but one of the side effects that patients complain about is burning. Intralesional corticosteroids are also something that we also perform at the hospital and in private practice, and this is great for localized areas such as DLE on the scalp. It works very well, but patients sometimes can't tolerate it very well because of the fact that you're literally injecting into the scalp, and it can be a little bit painful and uncomfortable, but it works very well. Now, lastly, ruxolitinib cream is an emerging topic. So let me give you an overview. Antimalarials used in autoimmune diseases include hydroxychloroquine, quinacrine, and chloroquine. And the most commonly available is hydroxychloroquine. HCQ was actually approved since 1956, and all patients who have lupus, unless there is a contraindication to start, should be on hydroxychloroquine. If partial or no response, you want to check the hydroxychloroquine levels and where appropriate and switch to chloroquine. Next, or simultaneously, you want to add an immunosuppressant if you believe that the patient's skin is so severe at the onset, or if there is existing systemic disease as well, or failure to the skin to respond to the antimalarials. Immunosuppressants are divided into systemic steroids and also steroid spares the effects. And this is a step you cannot miss. To take 200 milligrams in the morning and 200 milligrams in the evening. So that's some useful practical tips to advise your patients. Now, methotrexate is widely used as a second-line option for moderate inflammatory cutaneous lupus. I'm pausing. Okay, I'm pausing.
Is it not rectified?
Oh, I'm okay for now.
Are the slides back up on Zoom, is it?
Oh, I have nothing. What do you mean?
No,
What do you want?
I'll take care of it. You skip it? No problem, skip it.
No? Everything is okay? Just let me know when you'd like me to continue. Yep. Okay. All right. So methotrexate is widely used as a second-line option for moderate inflammatory cutaneous lupus. or if you want to use it for a patient who you're trying to really get off of steroids. So methotrexate is a DMARD, and technically it's not approved for lupus, but there has been so much real-world studies that no, it's just really one of the things that we use a lot. So with methotrexate, the skin improvement is usually seen about as early as 6 to 12 weeks, but sometimes you can see maximal results by 3 to 6 months. If a patient is having GI intolerance, which is very common, there's a couple things that you can do. You can actually try to give them the subcutaneous formulation. You can try to split the dose, and you can also increase the folic acid amount that you're giving them. Typically, we would give 1 milligram of folic acid daily or 5 milligrams per week. I know that different physicians choose to do different things, and sometimes just giving it every day enhances better compliance, I'm aware. Now, routine monitoring is going to be necessary, monitoring liver function tests, and also CBC. And then lastly, I think all the physicians already know in this room that methotrexate is highly teratogenic. So conception counseling is needed for patients, and not only that, but a washout period. So if you start methotrexate today, you need to wait at least 90 days before thinking to get pregnant, and that's something that really needs to come across. And then not only just really telling them that you can't get pregnant, you need an active plan. So do you have an IUD? Like, it needs to be properly discussed at every visit when a patient is on methotrexate. Because I've actually seen patients, unfortunately, come in when I was at Boston, pregnant and on teratogenic medications, and it was not good. All right, mycophenolate is effective for many cutaneous lupus patterns, and it's often one of the more potent steroid sparers. You can start at 500 milligrams twice daily and titrate all the way up to 3 grams per day. Patients may complain of GI intolerance with this as well, but mycophenolate can come in 2 different versions. So 2 different brands, Cellcept versus Myfortic, and they're different because the Myfortic has an enteric coating, which is released in the intestines, so you bypass any stomach discomfort, whereas Cellcept is actually started to broken down in the stomach, which can then cause irritation. So you may want to switch a patient if it's available and where appropriate, if they're having GI intolerance. Mycophenolate is also highly teratogenic as well, and it requires monitoring just like methotrexate I had mentioned before. Azathioprine, less data for the skin, but sometimes very important if you work through those 3 already and not getting the response you want, or if there's certain types of lesions like vasculitis or certain systemic manifestations, you may want to opt for azathioprine over the last 3 that I mentioned. And azathioprine is a tricky one because before starting, you really should be checking what's called the TPMT levels, because an abnormality in that can make you accumulate toxic metabolites. And what that does is that it presents with more profound myelosuppression, which can actually be very fatal. All right, so dapsone is particularly useful for neutrophilic disorders in lupus, and as I mentioned, it's first line for bullous lupus disease. You always want to check your G6PD levels before prescribing this drug, and you can start at 50 milligrams and titrate upwards. Monitoring your CBC while you're on this is important because dapsone can cause hemolysis of red blood cells, which can be mortal, and also can lead to methemoglobinemia and also neuropathy as well. So thalidomide and lenalidomide, they have very high efficacy in refractory cutaneous lupus, and there's really good data for that. With thalidomide, neuropathy was more frequent, but with lenalidomide, that was actually developed to augment some of those side effects of thalidomide. Both of them are teratogenic agents and require it requires contraception monitoring and counseling. And in the States, you actually have to join what's called REMS in order to even get this drug prescribed. And REMS is a program that looks at pregnancy, preventing pregnancy in teratogenic drugs. So it's a monitoring program. So with these two drugs, because they work so well and because of the possible side effects, you don't necessarily want to keep somebody on it very long. Once you start to get the effects that you desire, you can start tapering down to the lowest effective dose, or you could even try to taper the patient off altogether. Now, B-cell depleting agents like rituximab, very important and sometimes underlooked. This is a dosage that you could give. There are different dosing options, but 1 gram on day 0 and repeat on day 14. And this is an IV infusion usually done in hospital. And rituximab is really good for refractory cases. And there's also really good data for that as well. So if you cycle through everything else, this is something you may want to think about. Now, what's emerging and what's new? This is the exciting part. Okay, so belimumab, also known as Benlysta, was originally approved for lupus in 2011, and now it's actually approved for pediatric lupus and also lupus nephritis. Of note, this is exciting news because this is the first drug to be approved by the FDA since 1956, since hydroxychloroquine, right? So remember, the azathioprine, the methotrexate, and the mycophenolate are not technically approved, right? But we're using them because of real-world data. But this is approved. So post hoc analysis had showed that there was really good data for it versus placebo. And what they found was that it was specifically better in patients who had a lot of serological activity. There are things to monitor with this, such as mood changes, infection risk, and also non-melanoma skin cancer can also be seen rarely as a side effect. There are 2 formulations of this. There's an auto-injector, which is given weekly, and there's also an infusion, which can be given every 4 weeks, and that's also a weight-based drug. Now, I can confidently say that anifrolumab is the rheumatologic dermatologist's most exciting drug that there is right now, and that's because it works so well for the skin. So it's approved for lupus since July 2021, and it works by blocking the type 1 interferon receptors in cutaneous lupus. So it helps to downregulate the interferons which are driving the process. Now, there are 2 trials that looked at the efficacy of this in cutaneous lupus, and that's the TULIP-1 and TULIP-2 trials, and they showed significant improvement in cutaneous activity. There are some side effects of this drug, risk of herpes zoster and respiratory infections, and I've actually seen this quite a lot. So this is one of the drugs that you really want to emphasize updating immunizations. Herpes zoster vaccine should really be given with this drug before starting. This comes as an infusion. Patient has to come in. It's 300 milligrams IV every 4 weeks, and it's a really quick infusion. Sometimes you can do it in 30 minutes to 1 hour. So JAK inhibitors are considered as emerging therapy for lupus because none of them are technically approved for lupus as yet. And they work by targeting the intracellular signaling of interferon and cytokine pathways. Small open-label studies and case reports suggest good reports in refractory cutaneous lupus. And topical ruxolitinib cream has also been trialed for localized lesions, but not yet approved. The Paisley trial looked at deucravacitinib, which is a TYK2 JAK inhibitor, and that should be some exciting stuff that's coming up in the next couple of years. It's now going on to phase 3 trials. All right, so the newest biologic that's being investigated on the horizon is called litifilimab. And this is a humanized monoclonal antibody that targets the blood dendritic cell antigen 2 receptor on plasmacytoid dendritic cells. By binding to these cells, it inhibits the production of type 1 interferon, which again is a key factor in the pathogenesis. And the LILAC study looked at this. So the LILAC study investigated this drug, and it was divided into two parts, Part A and Part B. The Part A component looked at systemic manifestations of the lupus, and Part B looked specifically at the skin. So for Part B, what they noticed was that there was marked improvement in the CLASI scores with reduced skin lesion activity. And because of this, it's now going on to have more trials, and the TOPAZ study now is ongoing and is in the phase 3 of being tested. Side effects of this can include diarrhea, the common cold, but overall, so far, it has had an overall reassuring side effect profile. Lastly, so what's new in the world of lupus is CAR T-cell therapy. And CAR T-cell therapy is rapidly evolving for immunotherapy and is now being tested on diseases that carry a heavy B-cell driven response. So we'll cover the rationale, the clinical evidence, the safety, and the trial landscape of this. So to be included in this clinical trial, the one thing that you need to have, amongst many other criteria, is that you need to have refractory severe lupus to enter the trial. So it typically involves leukapheresis, ex vivo T-cell engineering, lymphodepleting chemotherapy, and then a single infusion of those engineered cells back into the patient. The CAR will recognize CD19 on B cells and lyse them, creating profound B-cell depletion and therefore normalization of serologies. And this is said to give a reset of the immune system. So this approach is very attractive in refractory severe lupus. However, the skin data from this is a little bit limited so far. But what they're finding early on is that once you have decreased the severe levels of systemic disease or systemic burden, the patient's skin has been responding very well. So hopefully we'll one day see studies looking specifically at cutaneous lupus in the future. All right, drug monitoring. All of these drugs require monitoring, and they also require special considerations as well. And this is really just a recap slide because I believe that I've said most of this as I was going along. So checking for drug interactions are very important between different drugs. For example, antacids, your lansoprazole, your pantoprazole, commonly prescribed. But you know, it actually can make your hydroxychloroquine levels less effective. So this is some advice you may want to give patients as well, right? And also possibly separating the time that you're taking your antacid and you're taking your hydroxychloroquine, right? And also that goes for over-the-counter things like Maalox and Fedogel, for example. Then also diabetics, very important, right? There's some diabetic medications which can interfere with hydroxychloroquine, creating hypoglycemia. So that's also something to counsel them about. And a number of other drug interactions here, as you see on the slide, which are very important to go through. Monitoring for osteoporosis while on long-term steroids, also very important. Optimizing your calcium and your vitamin D here and titrating to the levels that you want your vitamin D at. Also lifestyle measures such as weightlifting, also important for patients who can manage. Monitoring the eye while on hydroxychloroquine, we went through that earlier. So remember, you want to get your first tests within the first year, and then after that, you start at year 5 going onwards annually. However, if you have high-risk features such as renal disease, tamoxifen use, a high dose, you want to start your screening way earlier than that. Also, you need to discuss pregnancy and contraception with the patient in detail and having a plan, not just a wish. What to optimize: weight, smoking cessation as well, and alcohol limitation. And what to update: your age-related malignancy screenings, right? And also immunizations. And we mentioned earlier before the importance of certain vaccines, such as your herpes zoster vaccine. And the herpes zoster vaccine is typically indicated for patients that are over 50, but if you have a lupus patient on immunosuppression, this should be given at any age. It doesn't matter if you're 50 or not. All right, so special populations to consider. Remember, the washout period is necessary. And for lactation, there are pretty much not really a lot of studies looking at patients taking these medications with lactation. So this is something that you really want to advise them to discuss with their OBGYN and also with their pediatrician. Again, a multidisciplinary approach is needed to this. Skin of color patients, very important, because remember, once they scar, they have really bad contrast, right? So you have a white, depigmented area, and then dark skin, which doesn't look so appealing. So this is very important. You do not want to use laser treatments on this patient. Maybe they'll come and ask you their opinion. You want to ask them to consult their dermatologist. Laser treatment can be used in areas such as, like if you're having telangiectasia left over from any pre-existing disease, that'd be good for that. Cryotherapy, not usually very recommended either because of the risk of scarring as well. So you really just want to take everything into consideration. Raynaud's phenomenon. So we're going to end the presentation by going through a little bit about this here. So these photographs, they're showing Raynaud's phenomenon. So they're showing digital ulcers, ischemic digits, and also you can see cyanosed fingers as well. So Raynaud's disease, yes, it can be divided into primary and secondary. And for secondary, I want to highlight that connective tissue diseases are a major reason for this happening as well, right? So these are your treatments available and general measures such as cold avoidance, warm clothing, stress management, smoking cessation, important. And then there's a number of drugs that you can go through, which are first line, second line as well. Now for refractory cases, these are the ones here on the slide, and I want to highlight that at the University Hospital, we've actually been doing Botox for a number of patients with Raynaud's phenomenon, and it's been working very, very well. So if you have patients out there with Raynaud's phenomenon and they're having ischemic digits, please send them to us. We're happy to assess them, and we're happy to give treatment for that. And recently, we've also tried alprostadil at UWI as well. So alprostadil is a medication that's usually given to neonates to keep their ductus arteriosus open if they have congenital heart disease. But there's been a couple studies that have been looking at alprostadil for patients who have Raynaud's phenomenon, and it's been working very well. We've tried one patient on this, and she actually has reported resolution of all of her symptoms. So this is very promising. Again, if you have your patients, we're happy to see them and we're happy to assess. So I'm not going to go through this in detail, but this really just highlights Botox therapy and how it's given. This is where you would inject. There are a couple options. Different injectors will do different things. So the dots here that are on the slide are the injection points, right? So photograph A and photograph B are different. And the typical dose that we use per hand is between 25 to 50 units of Botox per hand. And you're really targeting those neurovascular bundles, right? But being careful not to go into the vein or artery. Now, this is the data for alprostadil. The data so far, there's quite a lot of data, but I wanted to highlight the data from Sri Lanka and Italy. Those two centers did alprostadil 60 microgram infusions, and Sri Lanka did it for 3 days. Italy did it for 6 days, but both of these centers found that the patients actually did better regardless of 3 to 6 days. For our patients at UWI, we gave her 6 days. All right, so this is how you'd write a high-yield referral note to the dermatologist. If you are sending your patient to us, we want to know the duration of rash.
1 second again. No.
I'm pausing.
Technical difficulties.
Technical difficulties on Zoom.
They're not hearing.
They're not hearing anything?
Lights have gone.
It's okay. Just let me know when we're good again. All right, well, in the interest of time, I really just have 2 slides left, and it's not a table or a photograph or anything like that, so I'll just continue speaking. All right, so in your referral to the specialist, to the dermatologist, or to the hospital, useful information to include in your referral notes would be duration of rash, systemic symptoms if present, photos if possible, adhering to the Data Protection Act, of course, labs already done, known drug allergies, past medical history, current and past medications. And as Dr. Ho had highlighted earlier, do not underestimate the role of drug-induced lupus and drug-induced subcutaneous lupus as well. So drugs is something we definitely need in that referral letter. And this is a slide showing, well, quick reference tools. And those could include things like UpToDate, Hippocrates, the ACR guidelines. And for patients, I like to recommend DermNet NZ. The information is broken down very well with small, easy to understand words, but really giving great accurate information as well. And for physicians, I want to highlight UpToDate and Hippocrates. This is very key for checking drug interactions. It really does give you really good, valuable information, how to go about monitoring if there is a drug interaction as well, right? And patients can get simple handouts from lupus.org. And these are the take-home messages here. So early recognition and intervention can prevent permanent scarring. A multidisciplinary approach is needed for initial diagnosis often, right? So it'll be the dermatologist doing one side of things, and then the internal medicine folks, and then the rheumatologist, nephrologist, and you all put the picture together to diagnose this patient. So collaboration is really key here. And lastly, the last take-home message here is start with general measures, and escalate upwards. Do not be afraid to escalate. Do not be afraid to combine therapy. Remember, the aim here is to get the patient better, not just on the inside, but also on the outside, because that's what everybody's seeing, and that affects quality of life. Thank you for being here, and I hope you guys enjoy the rest of the conference.
Thank you very much, Dr. McNeish, for such a cutting-edge, quite informative and beautifully delivered talk. I've learned a lot. Audience. Dr. Lowe Jones.
Hi, good morning, everyone. Dr. Ho, Dr. McNeish, thank you so much. I'm quite a bit as a nephrologist myself, so collaboration is key. I just wanted to know, Dr. Ho, what's the predilection for the ears with discoid? Is there some kind of embryonic origin of melanocytes? Because, you know, it's an ear that many physicians don't examine, so I just wanted to know.
So just for the purpose of the persons on Zoom, Dr. Lowe Jones just asked, what's the predilection for the discoid lupus in the ears? Is there an embryological association? You want to come?
Good question. So unclear. Perhaps some degree of trauma, some degree of just the same way that, you know, lichen planus likes the wrist. Why? So embryologic, like melanocytic migration at this point, not clear. So I think the easy way out is I don't know. But in this case, usually I say, I don't know, but somebody knows. I think in this case, nobody really knows at this point in time. But there probably is a component of trauma, like people cleaning the ears, etc., because we know that some amount of autoimmune connective tissue disease does do what we call kevnerize. So, you know, if you traumatize the area, you end up having skin disease at that site. But I don't think people are really digging their ears that much. That trauma could really account for all of it. And so I do think it's predilection. I also think that discoid lupus in particular, when we think about the histopathology compared with other forms of cutaneous lupus, has a striking predilection for the follicle. So all forms of cutaneous lupus, in addition to interface dermatitis, there is inflammation around the hair follicles and the sebaceous glands as well. But it's heaviest in discoid lupus. Now the ear and the head and neck in general is quite rich in follicles, but also in sebaceous glands. And so I suspect that there is some sort of antigenic predominance in these areas that predispose to it, but it's unproven at this time.
I wonder if it has something to do with sun exposure.
Dr. Braham was asking about sun exposure. I think yes. It's probably a mix of all things. The only thing is like deep in the ear, right? And if we think about the other like really photosensitive lupus rashes like SCLE or tumid, they don't like the air. So I feel it's a mixture of trauma and predisposition, maybe some actinic damage as well, but predisposition to this antigenic attack on hair follicles and sebaceous glands. But again, this is like my thoughts. I don't think it's necessarily right. Yeah.
Any other questions? I'm looking out for questions online also. So, may I ask a question? Two simple questions I had for Dr. McNeish. I wondered about mineral powder, in sunscreen protection and reapplication, the efficacy of it. And also, okay, we'll go with that first.
That's an excellent question. Can you hear me? Hello? Okay, good. Right. That's an excellent question. So, yes, those are on the market. There's a few available in stores like at Sephora, Ulta, Amazon, right? But can I give you a really good suggestion? Okay. So, a personal tip of mine is put the regular sunscreen on first, then use your face powder, your regular face powder, whether that's Revlon, Fenty, etc. Take a big fluffy brush and tap it all over. This gives you a really nice, smooth appearance, a nice look. It looks like you have a no makeup look on, and that for sure will guarantee that you're getting the efficacy from the sunblock that you're supposed to get, rather than guessing or spelling with the mineral powders.
Okay.
Same advice for the men?
No, for the men, boy.
See a male brushing on their mineral powder.
No, actually, so there was a slide that I didn't present, but some of these mineral sunscreens, well, a lot of the mineral sunscreens, they come as non-tinted, okay? So I know I focus a lot on the tinted sunscreens, but yes, that's an excellent question. A man would probably not want to use a tinted sunscreen for obvious reasons, right? So there are non-tinted versions. La Roche-Posay also has them, CeraVe has them, and a number of brands has them as well. But the key thing you really want to look for again is titanium oxide and zinc oxide, if it's not going to be tinted with the iron oxide.
Okay. Dr. Lowe Jones. Ms. Whiteley.
Oh, yeah. Okay, actually, I have a question related to the sunblock, so I'm glad we're on this topic. Well, a few short questions. First of all, the La Roche-Posay and the CeraVe, were those just for the face or were they full body sunblocks? And if they are just for the face, could you bring up the slide with the ones for the body one more time? And then last question, I believe you said you use the La Roche-Posay. So if so, what shade do you use for the La Roche-Posay? Thank you.
Great questions. Thank you. IT team, are you able to bring that slide up? I think it's going to be slide 19 or 20. Between 19 to 21, somewhere there. Yes. So the La Roche-Posay comes in 4 shades, as I mentioned before. I use shade 3. Yeah. The other question you had was if the first slide, if the CeraVe and the La Roche-Posay is only for the face, I would say no, you can use it anywhere you want to use it, but the tube comes in a 1.4 ounce size. So it wouldn't be practical to buy that to use on the body. That's going to be very expensive and just not practical. But I had a slide, the third slide, if you could advance one more slide. Yeah, this slide, great. These were my recommendations for the body, right? So the copper tone sunscreen comes in a very large size, so that's practical to use on your arms and legs. It won't be finished very quickly. And then the spray ones that are here are specifically actually made for body anyway. And I was highlighting those two because they're easy to travel and carry and reapply throughout the day.
And just as for the men in particular, like they also come as like sticks, like almost like deodorant sticks, and the spray. So those are like two, instead of, not, some guys are not really going to be willing to be like putting on the dot and rubbing. So the sprays and the sticks are actually good options for male patients.
Yep. And Sunbum actually comes in the stick as well, and Neutrogena also has some of those stick versions too. And none of these leave a white cast, so great for men and great for female. They're not tinted, they don't leave a white cast. Yeah.
And for men, you do have some mattifying sunscreens. So I know one of the big complaints with sunscreens is that it makes you shiny. At least for women, you can always put on a mineral powder over it to keep down some of that sheen, but they do have the mattifying ones so that men can use.
Yeah. The Elta MD, particularly UV Clear, has a very mattifying finish to it. I can personally recommend that if you like that finish.
Sprays are also cooling
as well. The Elta products.
All right.
Hi, morning again. For Dr. McNeish,
the anifrolumab, or for any of the rheumatologists or dermatologists here, do you do the herpes serology prior to initiating? One, can it be given in office, or is it a day case where the patient is admitted onto the dermatology ward? And two, cost and to the patient. And secondly, the Botox, is it ultrasound guided or blindly?
Okay, great questions. I apologize. I may ask you to repeat some of them, so in case I miss the latter half of your questions, so I don't miss any of your stuff. So first thing you wanted to address was the herpes zoster vaccination and how Safenlo is given. Okay, so for the herpes zoster vaccination, no, we actually don't routinely check if the patient has had chicken pox serology is positive before we routinely give it, because we assume that most patients have been exposed to it already anyway. So that was a practice at Boston University. We would just give it. It's given as 2 doses, so 1 at day 0 and then repeat in 2 months, and then you're said to be immune for the rest of your life, right? For the Safenlo, how we would give it is that we gave it in an infusion center. It takes about 30 minutes to 1 hour to be given, plus or minus any other eventualities on that day. I believe that the cost is about don't be scared, but about $10,000 US. However, this is something that we can work towards getting. A lot of the patients accessed it without any problems, but yes, Jamaica is a different place from the United States, I understand that, but hopefully one day, even if we have a generic version of it, or we have some type of partnership, or we can bring the health insurance on board to help to offset some of the costs to the patient, because it's a drug that really does work dramatically. Sometimes at the second infusion, the patient is almost clear already. And not only is it being used in lupus right now, but it's something that's now emerging in dermatomyositis as well, to not just help the skin in dermatomyositis, but also the systemic portion of it as well. So this is going to be a drug that's hot and upcoming in the next couple of years, and I'm hoping we can get it here in Jamaica. The infusion center that you mentioned, it's something that I also believe that Jamaica can look towards as well. If we had an infusion center here where all patients could access, come get their meds, go home, get monitored properly and appropriately. So there's a couple of things that I have in mind. Hopefully we can get them off the ground eventually. And your last question was?
Botox.
Botox, right? No, actually. So it's not usually done on an ultrasound guidance. You just do it blindly. Yeah. And adhering to your principles, you use a 30 gauge needle, you want to pull back on the needle, make sure you're not in a vessel, that sort of thing, and you go ahead. Inevitably, sometimes you cannot escape side effects such as weakness to the hands, but that weakness is temporary and it will go away in a couple of weeks. Yeah.
Thank you.
You're welcome.
So on the Zoom platform, Dr. Albert Liu had a question for Dr. Ho. Patients who develop squamous cell carcinomas from discoid lupus erythematosus, is this age-related or chronicity-related?
Thanks. Good question. So it's chronic inflammation related. So it's that chronic low-grade inflammation at that dermo-epidermal junction or around the hair follicles that chronically stimulates the keratinocytes, and over time, sort of atypical or malignant clones can escape the control of the regulatory immune system. So it's chronic inflammation related. And actually, it's not so much that SCC, squamous cell carcinoma, in DLE is sort of in and of itself more dangerous, but any squamous cell occurring at the site of chronic inflammation, so lichen planus, lichen sclerosus, wherever, is considered high risk for certainly local recurrence, but also for local, regional, and distant metastatic disease. So chronic inflammation is the cause. Because it's occurring at the site of chronic inflammation, the risk is higher for bad outcomes.
Okay. Thank you. Thank you. All right. I have been given my time check. So we will wrap up our first session, which I think was an excellent session, and I will hand over to our chairman, Mr. Cedric McDonough.
Thank you very much. Round of applause. Don't leave it. Very immersive. And you can take me on as a student. I like the idea, Ken, so you're going to establish a center for excellence. And we can talk about the financing. Yes. All right? Let me just invite Dr. Asana, a few tokens that we would like to hand out. Stacy? Great, man. You went Woolmers too?
I was Wilmas.
I went Woolmers with your dad.
Yes, yes.
They were a little older than
I
me.
get quite a gift.
Yes. Okay. You want to come to the front here? Mm-hmm. All right. The first one you have there is Dr. Brown. Mm-hmm. Dr. Brown, okay. Yeah.
Dr. Brown, on behalf of the Lupus Foundation, we'd just like to thank you for the time you took to come here representing the Ministry of Health. Just a small token of our appreciation. Dr. Jonathan Ho, my classmate, my colleague, my friend. Thank you for your expertise always. Thank you for your wonderful presentation and for making me a better rheumatologist. On behalf of the Lupus Foundation, we thank you.
Mm-hmm. And I might add Woolmerian. She's almost wearing the Woolmer's color, maroon and gold.
Dr. McNeish. Dr. McNeish, our keynote speaker, thank you so much for the time you took to come here and share your expertise with us. We are so very excited to have a rheumatological dermatologist. It was very exciting to listen to you. We look forward to collaborating with you, and the Lupus Foundation thanks you.
Thank you. We're going to break for 15 minutes, but can I just mention 10 minutes? A few of our sponsors, National Health Fund, that's National Corporation Bakery, Burrito, Jamaica National Bank, Grace, and we have Surgery Moon, iPrint Digital, AV Concepts, that the audio-visual people were there, and Rheumatologists Associates and Collaborative Care. Thank you very much. Thanks to volunteers. So 10 minutes. Thank you. You leaving?
No.
Okay.
Yeah. Good. For a picture? Or
Sure, go ahead.
front? Yeah. They got stuck.
Okay. Sure, yeah. Thank you. Thank you. Yeah. Fine. Good to see you. Sit back to sit down. Ready to go? Yeah.
Like here, right here. Is that okay if I write something?
Oh, yes. You practice and sit down. Okay, okay. Yes. Okay, on there, yes. Yes. Thanks. Can I take one with my camera with them? Oh, sorry. No, come on. Well, you want me to? Oh.
No, this side.
Oh, yeah, okay.
So you guys are talking.
Yeah. Oh, I can. Yeah. From St. John's. From St. John's up to the... Okay. Yeah. Oh, the lead. Oh, we. Okay.
And customer.
Okay, yes. Okay. For join. Yes. Drink and
You've been using it?
Seriously, if you need any financing, well, I mean, such a owns a bank, but I talk to my clients. And then the total work that is Lupus. Yeah. So Desiree was the one that I invited to Terrell a couple of years ago. Why is it Lupus is not such a so you ever told us you got
Last week? You mean 2 weeks ago?
Oh, see, you're Okay. Okay, everyone, could you take your seats? We're about to resume. And I will invite the moderator. I know we have a few people still outside. Pardon me? I call them, you know. Yes, okay. We're going to invite our moderator to the podium, Dr. Sandra McLeod, and I'll try to get the others in. 1 second. Yeah. Let me call them. Yeah.
2 minutes. It felt like 2 minutes. Right. Okay. Here we are. Join us back, people. We are ready to go again. Please come on in. Session 2 is going to be great. So come on in. All right. As we resume, I want to welcome those just joining us online or in person. As you hear, I'm Dr. Sandra McLeod, and I'll be your moderator. We've had a very interactive and informative first session, and we'll keep the momentum going with an impressive lineup of experts for session 2. So please come in. For this session, we'll be shifting gears a bit, and we'll be looking at putting your best face forward. Everyone knows that presentation, how you face the world, is important, and that how you look can significantly impact how you feel and how you interact with others. So the topics for this session are quite timely and relevant. First up, I have the pleasure of introducing consultant dermatologist Dr. Lorena Muir-Green, who is the head of dermatology at the Cornwall Regional Hospital. She's a graduate of the University of the West Indies, first completing a double major in chemistry and biochemistry before entering medicine. She then pursued postgraduate studies at Cardiff University in Wales, obtaining her MSc in clinical dermatology with distinction no less. She has a special interest in hair and scalp disorders, including cosmetic chemistry and hair care. And in 2013, she was awarded a prestigious fellowship in hair and scalp disorders from the University of British Columbia, making her the only dermatologist in Jamaica with a subspecialization in hair and scalp disorders. She's a member of the American Hair Research Society and the International Society of Hair Restoration Surgery, among others, such as the DAJ and the Caribbean Dermatology Association, where she serves as vice president. And she has presented regionally and internationally on the subject of hair disorders. She's undoubtedly highly qualified to speak to us on hair and lupus. Let us welcome her.
Good afternoon. Thank you, Dr. McLeod, for that lovely introduction. You see me masked up here because I have a bit of the sniffles, being a responsible person. All right, so let me get used to this. So the clicker goes to what direction? That? Okay, all right. Thank you. All right, so today we're going to go talk about lupus and hair. And essentially, alopecia is what we call a medical term for hair loss. And majority of persons will experience some sort of hair disorder in their lifetime. However, most doctors often trivialize hair loss and say, oh, it will just grow back. And unfortunately, in our patient population with lupus, you will notice that quite a few of, a majority of them do experience some amount of hair loss. And alopecia can be divided into two main types, non-scarring or scarring alopecia. And in our scarring alopecia, we have several specific types depending on the type of sorry, excuse me, a little bit. Let me just get some water, sorry. Yes, sorry about that. So depending on the cells that are involved in the destruction of the hair follicle. Now, lupus is a chronic autoimmune condition with various symptoms, as we have described earlier today, and up to 85% of patients suffer with alopecia. And there are two main types of alopecia and lupus: lupus-specific alopecia and lupus non-specific alopecia. Now, lupus patients can also suffer from other types of hair loss because, we're still patients, we're just humans. Some of us have androgenetic alopecia, which is your pattern hair loss secondary to your from your parents. Now, the scarring alopecia, I'm going to mention at the very end central centrifugal cicatricial alopecia, because a lot of times these patients are actually referred to dermatology and they turn out to have this condition. Now, previously, you guys had seen the classification for lupus, and I just wanted to point out here on the ACR EULAR classification that discoid lupus is the one that they mention, but for the Systemic Lupus International Collaborating Clinics, which is our research group, they actually mention non-scarring alopecia as a separate entity in addition, along with the discoid lupus. Now, again, as I said, lupus and alopecia, lupus-specific alopecia. And the main one I'm going to be talking about is discoid lupus, while with lupus non-specific alopecia, lupus hair, alopecia areata, and later on I'm going to be discussing telogen effluvium. So lupus-specific alopecia. Now, the main one that a lot of the rheumatologists actually send over for evaluation is the non-scarring alopecia in SLE. And this is predominantly occurs in patients with severe uncontrolled disease and can be confused with telogen effluvium, anagen effluvium. So telogen effluvium is where you get the hair shedding after you start a new medication or you're having a baby or something like that, while with anagen effluvium is the hair loss that you get during chemotherapy, or alopecia areata incognita. In the literature, you will see them talk about universalis, but alopecia areata universalis is a completely different entity. And you do have an alopecia areata incognita, which actually looks clinically similar to telogen effluvium. Now, the non-scarring alopecia is considered a distinct entity because it shows interface dermatitis, and which Dr. Jonathan Ho spoke about earlier, and the obscuring of the DEJ junction, which is a dermoepidermal junction, and this is also positive lupus band test. Now, a lot of these patients with this non-scarring alopecia can have proteinuria, and a lot of practitioners forget about this. The good thing about this type of alopecia associated with lupus is that the hair tends to grow back once you get them under control. And as you can see on the left here, non-scarring lupus alopecia, which you look at this person, you're going to think this person just has age-related hair loss, androgenetic alopecia. It's not going to look like similar to the patient on the right. Nothing that you can think of, but they might have something else happening. They might be complaining about joint pains, etc. Now, with discoid lupus, as nicely put by Dr. Jonathan Ho earlier, this is a lupus-specific hair loss, and it is a chronic cutaneous lupus, which it is a secondary scarring alopecia, but it is initially non-scarring. And exposed areas are the most affected sites. and the most affected area is your scalp. Now, 5 to 10% of patients have a chance of developing SLE over time, and 15 to 42% of patients may have a positive ANA. If left long enough without any active treatment, they may have permanent scarring over time, which can be quite distressing for our patients. And you usually have the erythematous patches with scaling, depigmentation with peripheral hyperpigmentation. And end stage, it can have vitiligo-like lesions. Now, you can see here, patient with follicular plugging, and this is one of the early lesions. And of note, the follicular plugging can be in late stage as well as early stage. This is an early stage patient with the pigmented macules that you can see here that Dr. Ho mentioned earlier before, as well as looking on the arms, looking in the ears, as he had mentioned before. Another patient, two of my patients here with extensive discoid lupus with erythema, scaling, and depigmentation. And unfortunately, when they present like this, it's very hard to get any hair to grow back, and you have to counsel them regarding this. Now, on trichoscopy, when we use our dermatoscope, we see follicular dots, red dots, blue-gray dots, which is more visible in lighter skin. However, just to remind everybody that because usually your scalp is covered, the skin of the scalp is usually shades lighter than the rest of the body, and sometimes you're able to see this. Sometimes when some of our patients come, their scalp is actually quite pigmented, and you can't see that, and that indicates some sort of inflammation is actually happening. And this is a patient with darker pigment. You can see the follicular dots in the hair. Now, investigations, as mentioned before, you'd want to do the complete blood count, UNEs, LFTs, your thyroid function test, CPK and LDH. You may or may not need to do the ENA panel for these patients. However, depending on their symptoms, it would be best to do so. And typically what I tend to do is the patient comes in, they have DLE, I do the full autoimmune screen. If they're negative, probably check back in another year or two to see if they're developing any symptoms and test again accordingly. Now, the biopsy is useful, especially in patients when you have the non-scarring alopecia, because you might be thinking, oh, this person is just androgenetic alopecia. But when you get in the family history, you realize that there's so much lupus or rheumatoid arthritis and other autoimmune diseases present in the family, so you decide, okay, let me go and do a biopsy just to see if they are having something going on here. And just in general, when a woman of African descent presents with alopecia, it's best to at least have a screening or ANA on them, because they might be presenting with lupus that way. Now, in the management of lupus-specific alopecia, you can, these are just a general table to discuss, highlighting the medications that we can use. And the most common, hydroxychloroquine.
Sorry. There's a sound problem again. And pause for a minute.
Oh, technical difficulties. Okay, we're good to go? Okay. So you want to start them on prednisone, especially when they're just presenting, to get them under control while their DMARDs are started as well. And those take a little while longer to actually kick in, like your hydroxychloroquine, etc., your azathioprine. And depending, we can also go with topicals, of course. You'd want to use a high potency, either your betamethasone or your clobetasol on the scalp, because hydrocortisone is not going to cut it. And we also do intralesional steroid injections, usually 1 month apart, to help to stimulate even more growth. And not the greatest here, but we can also use thalidomide in some of our patients with extensive DLE who are refractory to your hydroxychloroquine, etc. Now, lupus non-specific alopecia is, oh dear, I'm so sorry. So this is lupus hair. So lupus hair was first described in 1958, and essentially what is happening is that you have the friable kind of shortened hairs, especially along the hairline, and they're not quite sure what is the cause of it. However, but they think that it has to do with the increased a movement from anagen to telogen in these patients. And of course, because of that happening, the hair shortens over time. And it also thins out. Now, we also have other descriptors for this condition, so other people have noticed over the years. Now, downy hair sign, which just recently reported, is the same thing, the same kind of concept, where there is a regression of the curl pattern, which is quite unique in our population, and a lot of patients will say, you know, that my hair texture has changed, not quite sure what is going on. So in the downy hair sign, this is where you get the vellus-like hairs growing, and it's soft, baby-like hairs. And you can see it in alopecia areata, lupus, HIV, very pathognomic in HIV. And patients may not get obvious patchy hair loss, but they can get just generalized, the whole head thinning and changing texture over time. Now, patients may not necessarily present to you because, you know, due to slavery and colonialization, the whole thought process, oh, but my hair look pretty, man, why am I going to go to the doctor to actually get this sorted out? But really, actually, something is going on. And this hair now is the downy hair sign, not the greatest projection here, but when you see, you will see that these are fine vellus-like hairs, and they will get grow back and become more curlier over time when you treat them. Now, this I was trying to show here, the patient's hair is more kinky on the outside, and you can see the hair straightening right here. Silky hair sign, this was actually described in Lagos, Nigeria, and what they were doing was doing a prospective study from 2004 to 2009, and they found that this was more observed in several conditions, including HIV, rheumatoid arthritis, lupus, and I'm sure you can see it in other autoimmune diseases like dermatomyositis, especially when it affects the scalp, pulmonary tuberculosis, and Behçet's disease. And this is the table showing how many patients they saw and the distribution. Now, what to let you know, why does this happen? Now, African hair or curly hair of any kind, it doesn't matter the race, once you have curl pattern of any kind, your the hair follicle dictates the curl pattern. So it grows from a curved hair follicle, and the curvature is actually maintained by immunohistochemicals. So imagine your immune system is out of whack, so therefore your immunohistochemicals will also go and change. Now, similarly, you have patients with straight hair who also describe that they actually, they started new medication and their hair became curly, or they went into puberty and their hair became curly. So we're not quite sure why this happens to people, but depending on the situation, you can have hair either straightening out depending on your particular race, or the opposite, where the hair becomes more curly in other races. Now, we're not quite sure again the pathogenesis, but the thought process is that inhibited activity of transglutaminase in the inner and outer root sheath, which is involved in the enzymatic process of cellular protein cross-linking. That's one of the thought processes. They're also thinking that there is alpha-keratin rearrangement of the inner root sheath during the disease process. We haven't quite figured it out. We'll eventually, over time, because we're actually doing way more studies now. When I go to World Congress, a lot more studies are being done on African hair type. Now, you need to know is that there's no abnormality found in the skin of those affected in the Lagos study, and you will see the same thing here. The patients with lupus hair, when you actually do the biopsy on them, they don't really have much going on. Maybe in the early stages they might have what looks like DLE, but most of the time the actual scalp, skin of the scalp is actually normal. They also showed in the Lagos studies that persons who had this, there was some amount of chronicity of the disease, anemia of chronic illness, high ESR, and immunosuppression. So the same thing with the investigations of anybody who comes in looking like this. They said, "Doc, my hair texture has changed. I don't know what's going on. Can you help me out?" You would work them up for autoimmune disease and see if they are, because remember, a lot of times when the hair texture changes, they actually have kidney involvement, and you have to take that into consideration. Now, management is the same as what I had mentioned before for lupus-specific hair loss, and it's essentially the same thing: your topical clobetasol, or your betamethasone, intralesional Kenalog, your prednisone, azathioprine, etc. Now, non-lupus alopecia, everybody, we all remember all of this happening with Jada Pinkett Smith et al. And alopecia areata is quite often associated or seen in a lot of patients who actually present with lupus, and it can be confused with lupus. Now, the thing about it is that it is a non-scarring inflammatory hair loss that can affect anyone of any age, and as a matter of fact, you have a 1.7% lifetime chance of developing the condition. And it can affect the entire body, where the entire scalp, eyelashes, and body hair is lost, and it typically occurs during periods of stress. So around exam time, obviously patients coming in during CXC time, doing PEP, and they stress out because, and I had a patient like that, he came in during PEP, terrible, losing the hair, the school telling him, "Oh, you have ringworm," all sorts of drama, and I had to write a letter to say, "No, this is not ringworm." All of this just around the whole PEP, around the PEP time. Now, the cause of alopecia areata is unknown, but the hair follicle loses its immune privilege, and we consider it an autoimmune disease. And what happens is you get rapid transition from anagen to telogen, and causing the hair to just shorten and fall out overnight. And sometimes you can get alopecia areata incognito, again, when it just looks like generalized thinning, or you can wake up with gray hair overnight, and it's called and overnight graying, because they get attacked on the pigmented hairs. Now, often it is associated with other autoimmune diseases like Graves' disease, lupus, pernicious anemia, and it's seen in adults more than children more than adults, and in women more than men. And as you can see here, you get this patchy coin-shaped hair loss with retention of the orifices. When you look on the scalp itself, you can actually see the holes where the hair should grow back. This is the alopecia areata universalis, and where you get complete hair loss for the entire body. And so when they're saying that, "Oh, you get that with that," that doesn't make sense. This on the right hand, the far right here, this hair actually is a patient with alopecia areata incognita. So you would look at this patient and think, "Oh, this is just female pattern hair loss," and it's really alopecia areata. On trichoscopy, you will see yellow dots, exclamation hairs, white dots, and this is in dark skin. And when patient presents with this, you want to do autoimmune screening on these patients, but importantly, you actually, because I've had patients who were Smith positive, I do the ENA panel on them. I also do ferritin levels because ferritin is needed for the actual growth of the hair. And sometimes you have the ESR, CRP negative, and then the ferritin is sky high, indicating some sort of inflammation is going on. We also might do vitamin D levels and zinc levels because sometimes those can precipitate, especially persons who have a history of alopecia areata. So they had presented with alopecia areata in the past, the hair grew back and everything was good to go, and then all of a sudden it started again. They probably have like low vitamin D, which happens a lot more and is very common, and that precipitated the alopecia areata presenting again. Now, what is important for alopecia areata patients is that you need to do the lipids, the cholesterol, and the triglycerides because they are at risk, a high correlation with hypercholesterolemia. Now, treatment you can have with the oral prednisone or dexamethasone, can give them methotrexate, azathioprine, also JAK inhibitors such as the tofacitinib. The problem with oral therapy for alopecia areata, as soon as you stop it, the hair falls right back out. It's very ungrateful that way. Some persons do gluten-free diets. They've started studies to look at statins because of the whole link of with the hypercholesterolemia and seeing if that is will help these patients. Biologics can be used like the Dupixent because of its association with atopic eczema, and lots of things have been done like in microneedling, the platelet-rich plasma, scalp micropigmentation, which also can be used for your patients with the discoid lupus. Now, telogen effluvium, this is resting phase hair loss, and essentially have three main phases of hair growth. Your anagen, which is where you have the length. It takes the length of the hair, and it usually lasts between 3 to 10 years, while your telogen is where your hair goes into resting phase, and all the hair that you comb out is usually in the resting phase. Normally you get about 10% of your hairs in resting phase, and you know how much that looks like when you comb your hair. A lot of persons think that they have telogen effluvium when they actually have hair breakage. You must have the white bulb at the end of the hair shaft in order to consider it a telogen effluvium. Now, again, it can be precipitated by, it can be acute within less than 6 months or chronic more than 6 months, and it can be precipitated by thyroid issues, anemia, low zinc levels, low vitamin D levels. Now, how does this relate to lupus? Some persons may not present with this. They actually might, when they go in hospital, they have a flare of their lupus. Nothing was going on with their hair. They come out, discharged from the hospital, everything is good to go, and then 3 months later the hair starts to shed. And this is because of the illness. And other major illnesses can cause this as well, along with other surgical procedures, pregnancy, etc., etc. Now, persons, you have to advise them that they will never go bald. It's just that what happens is that their hair volume is a lot less than before, and they're like, "Doc, my hair was this big, now it's just this amount," and they're very distressed about it because a lot of persons are very attached to their hair. Unfortunately, with telogen effluvium, it can unmask other types of underlying alopecia, like your androgenetic alopecia, which, most persons will have some amount as they grow older, and scarring alopecias like your central centrifugal secretaceous alopecia. Now, these are some of the causes, as I said before: major surgery, post-pregnancy, poor diet, going on Ozempic, all of those things can also trigger telogen effluvium. And these are some of the medications that can trigger your telogen effluvium, and these include your Roaccutane for your acne, your acyclovir, your anti-epileptics, all of those things. Investigations, again, as I said before, I would do these investigations, including your iron studies, vitamin D, because if your ferritin is low, now if your ferritin is below 50, your hair will shed. It's ideally to be above 50 or 70. If it is below 50, your hair would definitely shed. So even if your hemoglobin is normal, if the ferritin is low, the hair will shed. Sometimes persons can have hair shedding with low magnesium levels. Treatment for this is really find the underlying cause, get that under control, and using topical minoxidil off-label to keep the hair in anagen as long as possible. And you have to warn them about the initial shed that you can get with minoxidil. Now, I want to go through quickly about CCCA. Now, this condition, it is not associated with lupus, but unfortunately, a good amount of the rheumatologists send over these patients asking if they're related or actually have lupus, and I have to write back them and say, oh, they actually have CCCA. And this is a condition, and I just wanted to just inform or educate the persons out there about this condition, because it's actually quite prevalent in our population, and it looks similar to androgenetic alopecia. The scalp is quite pliable, and unlike discoid lupus where the scalp can become hard over time, and it tends to look normal. And the thing about it with these patients is that they have a lot of itching, burning, tenderness, crawling sensation, bumps in the scalp, etc. And it's actually there's an inheritance pattern where you get at least one person in each generation having it, and men can get it, but black men, they just bald off the hair and call it a day. Unless they're having a lot of symptoms, they're not going to be coming to you for it. Now they have, sorry about this. On the left here is you have an occult version, first described by Dr. Calendar, where you have short broken hairs in the center and the normal hair, the rest of the hair growing as long as possible. This is a typical patient who comes in with like this, and I've had patients looking like that being sent over by rheumatology, being asked if this is non-scarring alopecia. And including this one on the far right here. They come looking like this, and this was a patient who was referred. And so it's just to inform you about this. Again, you'll think that this person is having androgenetic alopecia. And as you can see here with this person with the hyperpigmentation, again, and then this person here with the occult version. Now, trichoscopy, we will see peripheral white halo, erythema, and starry sky appearance. And these are some of my patients with, you can see some amount of peripheral halo and scaling up here, some erythema down here, and some halo down here as well. Now, investigations, because of the whole thing with rheumatologists sending over, and a lot of the patients saying when they come in already, they said, oh, I'm having this hair loss, oh, but I'm already a part of rheumatology clinic. I actually started doing autoimmune testing on these patients, and a lot of them come back, especially if they're coming brand new with this condition. And biopsy would help to actually confirm the diagnosis, and I would actually start them on medication for same. Now, what is interesting about these patients is that quite a bit of them can have either autoimmune disease, endocrine disorders, along with metabolic disorders. And we've had lots of discussions between myself and different rheumatologists with this, as well as the Dermatology Association of Jamaica and the CDA, regarding how often I see these patients with autoimmune disease presenting at clinic with this. Now, the treatment is actually hydroxychloroquine can be used, doxycycline, which is helped for the itching and tenderness that they get. The itching that they get is not histaminergic, it's actually the Cowage pathway. We also use finasteride, dutasteride, low-dose minoxidil, and oral metformin is being studied. Topically, we can use it's not oral. Topical metformin was just recently described in 2020 for especially recalcitrant cases, but most persons are started on high-potency steroids like the clobetasol, betamethasone, tacrolimus, along with Rogaine to just help to keep the hairs in anagen longer, as well as triamcinolone injections. We also use exosomes, hair transplantation, only if they're completely quiet, because remember, this is a scarring alopecia, and if you don't watch it, if you actually do hair transplantation on a patient who is who hasn't been quiet for at least a year or two without the need for medication or treatment, they will actually carbonarize and start all over again, unfortunately. Now, lupus and alopecia, I'm just going to end here because it was a lot, and there are actually other areas that I did not discuss, like tumid lupus, etc., because we don't see a lot of that. But 85% of patients with lupus can have alopecia. They may be the first presenting sign of SLE. Alopecia in lupus can be lupus-specific or non-specific, and interestingly, CCCA. I see a lot of that in our population. Patients can still suffer from run-of-the-mill alopecia, such as traction alopecia, because people like to put in weave, etc., or wear wigs, etc. Or they can also have androgenetic alopecia based on their family genetics. They can also have the unique, specific to our population, downy silky hair, or the lupus hair, silky hair sign, or the downy hair sign, and reversion back to the regular texture indicates improvement of systemic symptoms. So if the hair doesn't completely revert, it means that it's fully not under control. Thank you very much, and these are my references.
Thank you, Dr. Muir Green. So that was quite a comprehensive coverage. That out. And moving right along, my next speaker, I'm equally delighted to introduce my next speaker. He's Dr. Romario Thomas, who is the consultant dermatologist and head of the dermatology department at KPH, a National Chest Hospital. He's one of the first graduates of the very rigorous DM dermatology program at the UWI. He's also a member of the Dermatology Association and the Caribbean Dermatology Association, among other affiliations. Not only is he a highly qualified dermatologist, he's also an entrepreneur. He's the chief medical officer, aesthetic physician, and cosmetic surgeon at Janus Cosmetic and Medical Spa, and boasts a slew of certifications in aesthetic and cosmetic medicine from internationally accredited bodies. He's also founder and chief medical officer of the recently launched Absolute Skin Incorporated, an AI-driven dermatology app integrating advanced skin analysis and telemedicine with a supporting line of evidence-based skincare products for diverse skin types. He has seamlessly combined his knowledge of dermatological conditions with the practice of cosmetic surgery and aesthetics and the use of technology. With this unique trifecta of skill sets, he's eminently qualified to speak to us on aesthetic and non-pharmaceutical approaches to the management of lupus. Please help me welcome him.
Good afternoon, everyone. I'm honored to be here with the Lupus Foundation of Jamaica. As a dermatologist, we see not only the patients, but the person behind the illness. And we see the emotional toll, the scars, and the confidence that's lost along the way during this journey. And today I'll walk you through the aesthetics and non-pharmacological management of persons with skin lupus. and the ways we complement traditional therapy to improve not only the skin's appearance, but the patient's overall well-being and confidence. The goal is to show how cosmetic dermatology, when done safely and effectively, becomes a form of rehabilitation and not just total appearance, and helping patients achieve holistic renewal and to feel whole again. All right, so our topic for overview is exploring the aesthetic and supportive therapies in managing cutaneous lupus, with an objective to highlight the complementary roles of cosmetic dermatology in improving outcomes, confidence, and the quality of life in lupus patients. So, understanding lupus, we will not belabor these points. Dr. Ho and others who have preceded me went through them in totality, right? Just to understand that, chronic cutaneous lupus, especially discoid lupus erythematosus, is the most common and often leaves that lasting scarring pigmentary change. Patients struggle with hyperpigmentation, they struggle with erythema and atrophy, and which can significantly affect their self-image. They are not just cosmetic concerns, they impact mental health and social participation. So when we think about treatment, we're not only targeting lesions, but also the emotional healing process, right? So it has a very strong emotional burden, which studies that show the quality of life that's impacted, anxiety, depression, reduced day-to-day activities, all forming a part of the disease burden. And aesthetic interventions can restore confidence and a sense of normalcy and hope for these patients. When a patient looks better, they start to feel better, and you start to see better compliance with their medical management as well. So, the principles of the aesthetic management. When we consider any aesthetic management in the treatment of lupus, we need to understand that disease control comes first. Intervention should only happen when the condition is stable and there's no active inflammation. Now, there exist several different definitions of stability, but for me personally, and I think what is a guiding practice, is that stable means no flares, no signs of irritation or inflammation for at least 1 to 2 years. So that is a very long time, and we have to get them into that realm before we really dive down deep in aesthetics. Now, everything else builds on that foundation. So one, sun protection is non-negotiable, and Dr. McNeish spoke to us at length about, SPF, and I tell all my patients that SPF is daily medication. Gentle skincare is essential and is less often, and less is often more. And once stability is achieved, we can safely explore now the non-invasive procedures like options of peels, lasers, and fillers, whilst maintaining a conservative approach. So, cosmeceutical and topical aids, right? The right skincare routine is a cornerstone of the non-pharmacological management. And I recommend, cleansers, moisturizers that have ceramide-based, fragrance-free to support barrier repair. For pigment, we're looking for ingredients. So whether or not the brand is La Roche-Posay, CeraVe, Neutrogena, Absolute, we're looking for ingredients like niacinamide, azelaic acid, and kojic acid, which help with pigmentation. And these are safer alternatives for long-term instead of hydroquinone. Anti-inflammatory botanicals like Centella asiatica, vitamin E can soothe irritation. And of course, your sunscreen with your zinc oxide, titanium oxide, and of course, iron oxide, as mentioned earlier today by Dr. McNeish for photosensitive lupus. Now, let's go into camouflage and color correction, right? Cosmetic camouflage may seem simple, but it has profound psychological benefits. Right? Teaching patients to conceal erythema and scars effectively and instantly improves confidence. So we often recommend medical grade products like Dermablend or Cover FX. These are very good brands that are formulated for these kinds of patients, and they provide long wear as well as some form of SPF protection. So in color correction, we want to use a couple principles. Now, green neutralizes redness. So we're not telling persons to apply anything green to their face. But there are some tints and some additions of these pigments, so different formulations that we use green to neutralize redness. We use peach or orange for hyperpigmentation, and it gives patient control over how they present themselves, and this empowers them immediately. It gives them that sense of confidence when they're going out, going for dinner, going on the road, even coming to your office to see you. So that's where cosmetic camouflage would come in. Now, more advanced or a little bit more invasive are your chemical peels and microneedling. And despite the hesitance, they can be safely used in patients with inactive lupus to treat pigmentation and textural changes. I personally prefer to use mandelic and lactic acid because these are less irritating and kind of milder form of peels. Microneedling stimulates collagen and helps to smooth scarring, but only in disease remission, and you have to ensure that you have strict aseptic techniques, right? In addition to helping with scarring and pigmentation, of course, the intralesional steroid injections for persons who have lesions that have hypertrophied to become like keloidal, we can also incorporate that as well in the management. Again, bearing in mind that we don't want to be heavily traumatizing areas that are active in a disease flare. Especially microneedling, those of us who are practitioners of microneedling, we always want to avoid aggressive treatments that can trigger inflammation and kebnerization. So the needle depth should not be too high, something very minimal. And because the goal is gradual, controlled improvement over multiple sessions, it's not just going to be corrected in one go. So we move on to laser and light-based therapies. Now, laser and light-based therapies must be handled cautiously. But they can yield excellent results in the right patient. Pulse dye lasers and IPL are very helpful to reduce redness and telangiectasia that we know we can get with some of these cutaneous autoimmune connective tissue diseases, lupus, stuff like that. Now, fractional non-ablative lasers can soften scars and improve texture. And there's evidence to suggest that low-level laser therapy has anti-inflammatory benefits as well. So we're going also beyond just the cosmetics now in also like disease suppression. But anybody you're going to treat with lasers, one, ensure that you have, experience with lasers on healthy skin. You have very good patient selection for the patients who do have lupus. And then we want to start with patch testing and very conservative parameters. We're only treating quiescent lesions, and the key is to avoid flares and prevent other pigmentary complications. Now, dermal fillers. When we think dermal fillers, we think about Russian lip flip and projecting the chin, getting the nose straight because you never name Thompson, you want to name Vladimir, but dermal fillers, we use it for our patients as well, and I want to become a proponent, of our patients with these illnesses to seek more cosmetic interventions because it's not hopeless. There is hope for us in terms of new drugs coming out with your disease internally, as well as new therapies for the aesthetic appearance. So in conditions like lupus panniculitis, which often leaves deep atrophic scars and contour deformities, especially on the face, we use dermal fillers, especially those that contain hyaluronic acid, which is both immediate, restorative, and reversible. We can also use stuff that contain PLLA, like Sculptra, which was FDA approved for its first use with HIV-associated skin atrophy. It has applications as well for atrophy in cutaneous lupus erythematosus. For more permanent corrections, the autologous fat transfer is a stable option. So we're not only transferring fat for curves, we're also transferring it for confidence and to help with the aesthetics of our patient. And there's a lot of evidence. Well, I don't even think it's evidence. No, we all know that fat cells have stem cells in it. So not only it is correcting the volume, but it's also improving the texture and appearance of the skin itself. So it's a dual benefit to do fat transfer in patients who have lost, skin volume due to these conditions. Again, aseptic, trained, and conservative application. Another method that we incorporate is PRP and regenerative therapies. PRP means platelet-rich plasma, which is harvested from the patient's own blood and platelets. It promotes collagen formation and tissue repair, and its use in lupus can help with scarring and hair loss, once the inflammation is controlled. So we do microneedling usually, and combine that with PRP or inject the PRP directly into the dermoepidermal or in the superficial dermis junction, and we start to see benefits in little weeks. We start to see new hair growth, stronger, thicker hair strands. So PRP is a very good alternative to use, addition to use to your topical and oral therapy. Again, we want to ensure and we reinforce that patient selection is very important. In addition to PRP for the scalp, we have a lot of other scalp restoration techniques where we can use low-level lasers, camouflage techniques, minoxidil, hair transplant, hair fibers, permanent tattooing, pigmentary change using micropigment. A lot of these are basically coming to the forefront right now and becoming a little more popular in Jamaica. I think we are a part of a generation that is moving forward and removing aesthetics and cosmetics as the taboo, and seeing how we can incorporate it not only for persons who want aesthetic benefit, but patients like our lupus warriors, some of which are here with us today. We can't avoid mentioning, even in the cosmetics, the psychological and emotional support that we need to give our patients. It's about treating the person and incorporating emotional and psychological support into their day-to-day. Encourage them to seek counseling or join groups. Even a simple reassurance or guideline of what's possible will help them in their day-to-day. It's important when discussing cosmetic management with patients with cutaneous lupus for them to understand that we're aiming for progress and not perfection. Perfection, even where it was, if it were possible, because of the nature of the illness, we can't be too aggressive. So we just want slow and steady progress. So let's see some cases where these things have been implemented and these aesthetic techniques have been implemented. So case one, this was a patient with discoid lupus with post-inflammatory hyperpigmentation that we were able to improve with mandelic acid peels, home care with a brightening line, as well as tinted SPF. So again, after some treatment, you can see that she started to improve in terms of pigmentation. Lupus paniculatis, you can see the obvious loss of contour here in the mid face, also had in the temporal area as well, and this is autologous fat transfer into the mid face. It's quick and simple, taking fat from the arm. I think this patient had it from the inner thigh, came from the belly. It goes through a nano fat processing technique, so the fat cells that we transfer into the face are a little bit more processed than the regular transfer that we'll do into like for a BBL or something like that. They're smaller, finer, enriched with PRP oftentimes, and then it's injected into these areas, and then you can just see like this immediate difference. I mean, this is a whole new look on how you see yourself. You're not putting your illness forward, and I think that's one of the biggest things, especially when it affects the face. They feel like the first thing that people see is the illness. So these cosmetic management and therapies are very important, because after you've lost this atrophy, no matter what regime you put her on, she's not going to regain this naturally, certainly not within months to years. Lupus alopecia patient who had hair loss, of course, we did PRP and then some level of cosmetic camouflage. This was helped with microneedling. So microneedling is not only for eyebrows and stuff like that. It can be used to restore the hairline. So when the PRP has given you some follicular regrowth and some hair regrowth, you augment it with microneedling tattooing. So all of these have combined to have, some very, very good cases and outcomes. So again, no long talking. It's just to show the takeaway message is comprehensive care includes medical, aesthetic, and emotional. And no matter what practitioner you are, emotional is something that we always have to have for ourselves and our patient. But whether you're primary focus on aesthetics or you're primarily medical, I just wanted to point out some of the techniques that we can use today that are safe, staged, evidence-informed cosmetic interventions that will improve and enhance the quality of life of our patients. And, I'm so proud to be a part of the first cohort coming from the dermatology program here in Jamaica. And I'm extremely proud of Dr. McNish. I tell her she motivates me. And she does. She always says, "Oh, you're so doing this." I'm saying, "Listen, I draw so much motivation from you, because this is something we've talked about so much while we were in training. Collaboration with the rheumatologist and the dermatologist, and cosmetics. And I think there are exciting things on the horizon over the next months to years. Developing a room derm clinic with room derm cosmetics. That's what we need to be giving to the public, not just for private. Somebody or strongest lupus warriors are in our public system, and they are the persons who need access to this kind of care. So we want to empower patients with knowledge and options. And I'm so proud of the Lupus Foundation for helping us do that. And thank you for giving me this platform.
Wow, wasn't that a complete expose? I learned so much. Now, we regrettably do not have our third speaker, who was supposed to be Miss Gaudia Chavans, talking to us about makeup and skin confidence to round it all out. So that means that we have extra time for questions, and we'll move right into the question and answer sessions. So for those of us in the room, if you can head to the mic with your questions. And I'll start with one for Dr. Muir Green. I'd like to ask you about wigs. Wigs, of course, are a camouflage, but they can cause quite a bit of trouble themselves. How do you advise people the choice of wigs? What should they use? How should they put it on, etc.?
So, you can hear me now? Hello? You can hear me?
Right, so for wigs, there have different types. You have lace fronts, you have partial wigs, you have full closures, all sorts of different closures that you can use. Now, different things require different application to the scalp. You do have persons who tend to glue on the wigs to the scalp, and then they never take it off for another week or so. The glue themselves can cause issues because they can become allergic to the glue over time. the pressure of the wig onto the scalp can also cause pressure alopecia. So there are several things they have to take into consideration. So it's best to actually have persons remove the wigs on a daily basis, preferably not to be glued on unless it's, majority of the scalp is gone and, they just want to jump into the pool and nobody wondering what's going on with the wig floating by. So and that has happened. You see them on the TikTok and your Instagram videos. No, they're useful, but they do have their drawbacks, unfortunately. And so I tend to tell persons moderation is key and try to rotate your different styles, etc.
Thank you. Now, Dr. Thomas. Dr. Thomas said something I think each of us should just put somewhere. We're aiming for progress, not perfection. And I think that this must be a life statement or something. But I wanted to ask you, Dr. Thomas, about the camouflage. Every warrior needs camouflage at some point. Camouflage and enhancement. Is there a place where patients can be taught how to apply this camouflage? You're talking about the green and the pink and whatever. How do they go into a beauty shop, for instance, and figure this out?
All right, so I wouldn't say unfortunately, but we're not there yet where the MAC and the Sephora and those places are offering that type of tutelage to patients, because again, the focus is not on our patients who are having these conditions, the general public. So to answer that part of your question directly, there is no place currently that they can go into to be taught about how to blend the particular ingredients. But the websites like dermablend.com would offer blogs and articles and tips about what products are best used based on your skin type. And honestly, makeup is trial and error. Any woman here know that can say she's good at makeup and never been to a course is you tried it over time and you got better as you go along, right? Same thing can be said with your own application of camouflage. Just trying out the products, the medical grade ones, to see what's best for you. And in terms of other avenues of camouflage, the permanent or the semi-permanent type, there are a few practitioners out here who also do that, but again, face forward is the ombre and the eyebrows. But there are a few that I personally worked with who can also do for persons with skin lupus as well. So I want to put a more highlight on those things as we go forward.
Thank you so much. And I see Dr. Ho and a line up behind him, so we'll just go straight into your questions.
Thank you, Dr. McLeod, and thank you, Dr. Muir-Green and Dr. Thomas, for your talks. I had one question for Dr. Muir-Green and two questions for Dr. Thomas. Lorena, I totally agree that the silky hair story needs to get more attention. My personal feeling, especially with both the silky hair as well as the non-scarring alopecia of lupus, which is consistently said to be, it's like a telogen effluvium, but I think it's inflammatory. Because when dermatoscopically, sometimes it looks a lot like alopecia areata. And initially I was like, well, is it that I'm missing alopecia incognita or diffuse alopecia areata? But I don't think so. I think that these patients, it's too frequent. And, low-dose intralesional Kenalog or triamcinolone seems to help to bring back some of that non-scarring story. So I wondered if that was also your experience, one, and two, I would really like to collaborate. I know we've been trying to get this off the ground, but on silky hair, non-scarring alopecia work with you and with rheumatology. So it's something we've been talking about at UHWI, but I know you have like a huge cohort of patients as well, so I'm super interested.
They do benefit from the intralesional Kenalog for patients with the non-scarring alopecia. And the whole silky hair thing, I think we underestimate how much it actually represents what is going on in the body. You're hearing me now? Okay. Yeah, underestimate how much it actually represents what is going on in the body. And I really would love to get some because I do have a lot of patients. It's just some persons have approached me to, they want to do some work in hair loss, so maybe we can discuss that afterwards.
Okay. For Romario, I mean, just like Romario said, and I don't want to make a whole like UE residency program thing, but I am so proud to see the two graduates just sort of showing their expertise and mastery of their various, areas of subspecialization. So, enjoyed the talk a lot. I had a question, though, about hyaluronic fillers in patients with autoimmune connective tissue disease. So I think because people feel that mucin, which in essence is hyaluronic acid, is pro-inflammatory in autoimmune connective tissue states, people avoid using hyaluronic acid. My personal feeling is, and if you look at the literature, there's like zero evidence to suggest that that's actually true. And there is data to suggest that patients with scleroderma and lupus panniculitis, have been successfully treated with hyaluronic fillers without developing new lupus. Now, there are some case reports of like tumid lupus after hyaluronic acid filler. So maybe there's a story there, but my personal feeling is it's kind of overplayed. Like we're too afraid of using hyaluronic acid fillers in these patients, once they're quiescent, of course. Do you, one, have an opinion on that? And two, have you used HA fillers in patients who have autoimmune connective tissue disease?
Yes. So my opinion on it is definitely, you hit the nail on the head, is patient selection. Selecting patients who are outside of active disease, not having flares, I think that in at least my personal opinion, it's not a whole lot that we've done. We have not been seeing any flares induced by hyaluronic acid fillers. And if I may dare go a step further to say that in the few that we've done hyaluronic acid fillers in, the area, I always get the feedback that the skin itself looks good, not just the volumization, but it seems to change the appearance and the quality of the skin itself. So whilst there may be study about the flare and of course the theoretical mucin being hyaluronic acid, it's not something that I've seen in real world practice.
And my next question is, you're offering things that the current residents cannot experience because of our limitations. Can we send some residents to work with you for some experience? Thank you.
Sure, definitely we can. We have what we need to do is get more patients willing to seek, cosmetic treatment, not believing that they have to live with this. And the more patients we see, the more I'll be able to teach.
Right. Just before you, Dr. Edwards, there's a question from Zoom along the line of procedures. How do we know who are certified to perform some of these procedures? That's an excellent question because, we do know that if you don't do things properly, then we end up with a mess. So how can patients identify?
Yes, so definitely there are standards of certifications that are required to do these procedures, and not every certificate is the same, right? I think things that we need to look for, firstly, are professionals who are, the specialists in the field. So dermatologists, persons who are members of the DAJ, of course, even if they don't have that sub-level of specialization, they at least have that knowledge that dictates safety, because they will now be the default in terms of, is this disease active? Is this something that I can go and do? And if there is a flare, how can I manage? And I think that's most important. So even if someone has a certificate in aesthetic medicine or a certificate in laser, they're not necessarily safe to laser your lupus, because they can't properly assess a flare. They can't assess the quality of treatment that you're on. They can't assess the interactions with the medication, and they certainly cannot manage you if you go into a very serious flare. So I think you as a patient need to look on the medical side of the qualification first as the foundation, and then you can look at, okay, what is your cosmetic training? What are your outcomes? Cosmetics is very face forward, so it's like going into a tattoo parlor or whatever. You want to see that booklet. Let me see what you've done. So arming yourself with knowing what the certificate's qualifications should be, and asking for that information, their experience, their work, is something good that you can have when you're selecting a provider.
That's an excellent answer, and it shows that it's a holistic approach and not just a one-shot here and there, and that you need people who are qualified, trained, knowledgeable. Over to you, Dr. Brad.
Okay, so I'm Dr. Bradley Edwards. I'm a general surgeon and a general practitioner. So you may be wondering what I'm doing here. But I'm here mainly for the general practice point of view and getting some CMEs. I was really pleased to hear what I'm hearing. I didn't know most of these things, to be honest, about fat transplant and all that kind of thing. I'm amazed that these things are actually happening. What I'm wondering, so two things. One, Dr. Thomas, I heard that you had some interest in telemedicine. Because I work in a rural area, I always think that my patients probably would benefit from some telemedicine referrals. So if I had like a dermatoscope that I could send signals through to somebody to just do a referral, and instead of them having to travel all the way from Moko to Kingston, if I could get somebody to just have a consultation with, so we could at least start treatment based on your, interaction. I don't know how good telemedicine is on a dermal camera would be in making a diagnosis, for example, with all the clinical presentation. Can you give me some, if that can actually work?
Well, definitely. So, not to speak a lot, but as I said, I have a very strong interest in tech, and we're actually in the process of launching a beta app now where patients will be able to scan and analyze their skin from the comforts of their home, and then they can connect with dermatologists via telemedicine. So, yes, telemedicine is a very, think about it. It would be one of the specialists or the specialties that most fit telemedicine because it's very visual, right? So we are onboarding something very similar soon. It's so funny that you say that. But for even a more impressive backend where we work with doctors and general practitioners like yourself in office, the technology is out there. Anywhere we have a problem and we have an idea, the solution is out there. So even if it means, even myself and my company going back to the end and say, okay, let's make a version of this technology for providers, and now we can see dermatoscopic images and route pathology to Jonathan. That's very easy to do. Okay. So we're looking over the next couple of months to a year to have that capability to persons like yourself, a general practitioner, in a Lupus Foundation. It's very impressive, and I must congratulate you for being here, and that's what we're looking to do over the next couple of months to years.
Okay, one question to Dr. Mira Green, because I think she's the one that got me to get up out of my seat. You were mentioning alopecia areata, I think, and you were saying that the body, for some reason, starts attacking the hair follicle. That's what you said in your presentation. I have read somewhere that a lot of these autoimmune diseases come from, the basis of it is self-hate, right? People hate themselves for whatever reason. And I realize that they're under stress, and so there could be an extreme of people's response to stress that involves them actually hating themselves. Has anybody ever thought about that? There's some place I'd read it about autoimmune disease and self-hate. I don't know if that is
I don't know. I'm not aware of that as well, but
the thing about self-hate, though, is that when you start to get these conditions and you're scarring and whatever, that can drive some of that. So is it the chicken or the egg that we're seeing there?
Yes.
But what I said is that the body turns on itself, when you hate yourself. But anyway, just a thought.
Well, I would like to say, though, that since chikungunya passed through the island, level of autoimmunity has risen exponentially. We see a lot of skin manifestation post that. And the same thing with COVID as well. We're seeing a lot more autoimmune conditions developing post that.
All right. Dr. McNeish is up at the mic.
Hi, good afternoon again. My comment isn't medical, but it's actually cosmetic. So I have also gotten that question about makeup. How do I learn how to do what to do to camouflage, etc.? So I actually have a comment, not a question. There are many makeup artists available in Kingston, Montego Bay, and in other parishes actually that host teaching sessions. They have small groups, about 6 to 8 to 10. I know personally the makeup artist that I use, she has classes like that. So there's a few of them around. If you're willing to make that small initial investment as a patient to really know the products to use and the steps to go through, because I agree it can be overwhelming as well, right? To know what to do. So just arming you with that extra bit of knowledge. Thank you.
Thank you. And now we have.
Good afternoon. Audrey Malcolm,
Audrey
Lupus warrior for the past 27 years. My initial question is to Dr. Murray Green. I know you mentioned about gray hair, because I've been graying for the past 30 years. And I associated it with lupus, but no one confirmed it until you said something a while ago. But my question is it reversible at any point?
So it depends on the cause. So in terms of for persons with like lupus hair, or like for instance if they have associated alopecia areata, they can reverse with treatment. Usually they tend to take a long while to get back to the regular color. They might come back mousy brown looking and then eventually become darker over time. But it for some persons, depending on their predilection, because some persons just gray earlier naturally, it may not happen, unfortunately. But it can improve over time for some persons, yes.
Okay, thanks. My next question is to Dr. Thomas. The whole aspect of cosmetology and aesthetics, it's just a comment. If when the doctors are looking into it and the treatment, it can make it more cost effective, because having lupus is a very, very expensive disease. So it's just something to bear in mind that when these programs are coming in the future, if it can be a little more cost effective for us, the patient.
Yeah, definitely. Thank you for that. I think it's a stepwise battle, because even getting lupus recognized on some of the government subsidies and stuff like that is just a hurdle that we just started to get over. So now to tell the government that they need to add skin tattooing and hyaluronic acid, I think it should be there, but definitely I think what we as providers and the Lupus Foundation need to do now is to let the population and our leaders see that this illness doesn't only have the medical component. The cosmetic component is just as effective. The psychological component is just as effective. And that way we can now have subsidies for these ingredients, fillers, stuff like that. I know once we have the providers, because in private practice, those persons are coming to you asking for a brand. They come and say, "Oh, I want Juvederm because I've seen Juvederm," but there is hyaluronic acid that's 10 times as cheap as Juvederm, that's twice as good, that's being used, but that's not what being asked for. So I'm saying that to say the cost that you see and you perceive, it doesn't need to be anywhere as high as that. So I definitely think that is something we can have in our public health system, as long as we have the persons who are trained to do it.
Right, so many questions, so little time, and we'd like to just thank our two speakers. This was an excellent session, if I do say so myself. And we'd just like to invite Dr. Hagley, yes, to make some presentations to our two speakers.
So, to both of you, on this improvement to our knowledge base for our clients, patients, biopsychosocial, and no good health like mental and emotional health. Thank you so much for the knowledge that you've imparted to all of us, providers, patients, our lupus warriors. Dr. Muir Green, for your stalwart work. Thank you so much on behalf of the Lupus Foundation. And to Dr. Thomas, on behalf of the Lupus Foundation, thank you so much. We see the passion, and we appreciate it, and we look forward to further collaboration and work. Thank you on behalf of all Lupus Warriors and Lupus Foundation.
Thank you very much, doctors, for your heightened level of perspicacity and sagacity. Thank you. Emily will do a musical item, and we will break for 15 minutes, and we want to have you back here, everybody. All right, Emily?
Thank you. Hold on. That's good. Thank you. Good afternoon, everyone. It's good to be here, and thank you for coming out to be part of this important part of awareness for lupus. It can be a very heavy topic for patients, caregivers, clinicians. So usually my go-to is music, and I hope that this will lift you. I think you know this one, so please feel free to sing along, dance, do whatever. Here's a little song I wrote. You might want to sing it note for note. Don't worry, be happy. In every life there is some trouble, but when you worry you make it double. Don't worry, be happy. Don't worry, be happy now. Don't you worry, be happy. Don't worry, be happy now. Ooh, 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 ooh. So don't worry, be happy. Don't worry about a thing. Don't you worry about a thing, 'cause every little thing is gonna be alright. Don't you worry about a thing. Don't you worry about a thing, 'cause every little thing is gonna be alright. Rise up this morning, smile with the rising sun. 3 little birds sit by my doorstep, singing sweet songs of melodies pure and true. Singing, this is my message to you. Don't worry, be happy now. Don't you worry, be happy. Don't worry, be happy now. Don't worry about a thing. Don't you worry about a thing, 'cause every little thing is gonna be alright. Don't you worry about a thing. Don't you worry about a thing, 'cause every little thing is gonna be alright. Thank you so much for having me. Enjoy the rest of the day.
Right? So please, at any time that you see that we call you, that you support us, please, some of our staff or our students are affected by this condition. So it's a condition that does not have any, unlike cancer that everybody knows, unlike all other diseases that everybody knows what you can use for curing it. It doesn't have a cure yet. So we are saying that when we call you as a friend, as a family, or as a neighbor, that okay, we are asking to join the cause for lupus, please always join us, because it's not known to most people in Jamaica. Just that you are looking okay, you are just pretending. That is how it is. And the color for it is a purple. And those ones that have the discord, you are going to see a purple butterfly on their face. That's why. So we are asking you to please care for each other and try to ask, are you okay? If they want to tell you, they will tell you. They don't want to tell you, fine. Just be careful. If somebody say they are not feeling well, just try to just understand their condition. So thank you very much. This is our Miss Obi. Right. She's a warrior. We call our those persons affected by lupus warriors, right? She's a warrior. She's also a past student of UT. Right? So she understands the past farmers. It's a class. When it's to a class, not UT. So we are asking you to please speak to each other as well. You don't know what is going on. And based on statistics, affect money black and African heritage, which is where we fall on, right? And it affects men are affected but not as higher as a female. Right. So please, it's not a deadly disease as long as they can keep their stress level as low as possible. Right? It can be managed. Right. So thank you very much. We just want to count the number of students that support us for today. So we are going to start by 1, 2. 12. Okay, come on, let's do it.
But they have
everyone. Welcome back. Just a couple of announcements. You remember it's Lupus Awareness Month, and the Walk for Lupus is next Sunday. That's the 19th of October. And you can make donations online. There are some pledge cards outside, and you can sign up for the Laps for Lupus. And we have some merchandise at the back, to support Lupus Foundation. So I'm encouraging you to support wherever you can. So the online, you can register, you can make donations online, and you have the pledge cards as well. All right, Dr. Stacy? Mm-hmm. Something. She said something, but I don't even understand. I know, yeah. Let me see. All right. I think we have some problem with the AV, so we'd want you to show the promotional thing, right? With the 40th anniversary and some other stuff that you can see. Yeah. All right, but I want to thank you for participating, and I think we have the first session, some great speakers, and I certainly learned a lot. We're just trying to round up the others outside. So the next session, we'll be talking about patient-centered research and voices. And our moderator is Yannick Sanko-Valentine. I think she's here. Or she's still outside? Okay, she's right here. So I'm going to turn over, Yannick, you ready? Yeah. All right, I'm going to turn over to Yannick. All right, Yannick? Thank you. Yeah, good.
Good afternoon, everyone. My name is Yannick Sanko-Valentine. I'm a lupus patient, and I currently serve as a board member with responsibility for services. In this session, we will focus on the needs of lupus patients. As most of us know, lupus is unpredictable and affect each person differently. This is why constant research and need assessment are essential to help patients identify ways to manage and live with their symptoms. And with that, I will be introducing our speaker, which is Dr. Charlene Jarrett. Dr. Charlene Jarrett is a clinical psychologist and public health scientist with over 20 years of experience in mental health, HIV care, and public health research. She previously led HIV monitoring and evaluation and research for the HIV STI program in the Ministry of Health and the National Family Planning Board. Since 2016, she has led PEPFAR funded HIV technical assistance programs in Jamaica and Trinidad and Tobago for the University of California, San Francisco, and currently Caribbean Vulnerable Communications Coalition. Her current research examines the intersection of HIV and non-communicable diseases. She is passionate about adopting data-driven approaches from the HIV field to improve diagnosis, linkage, and care outcomes for people living with NCDs. Dr. Jarrett completed her BS in psychology at Cornell University, a PhD in clinical psychology at the University of Massachusetts, Amherst, and postdoctoral fellowship training in HIV clinical and behavioral research, and MS in biostatistics at the Mailman School of Public Health, Columbia University. Help me welcome Dr. Charlene Jarrett.
Hi, everyone. Afternoon. Thank you so much to the organizers for having me back. Last year was my first year presenting, and we shared the plans to do the needs assessment. And over the past year, we've made a lot of progress in implementing it. Make sure, what am I doing? Yes, in moving forward with it. So I'm happy to come back and share some of the preliminary and emphasis on preliminary findings from that study. So the goals for today describe the our efforts to develop a peer support training curriculum for lupus in Jamaica, share the preliminary findings from surveys and from some qualitative interviews, individual interviews, and a focus group, and talk about the next step. So for those who would be new to hearing about this project, the goal of the project was to develop an evidence-based peer support curriculum for lupus patients in Jamaica and to ensure that the content is relevant and tailored to the needs of Jamaicans living with lupus. The team, Dr. Tullereed, myself, Vivian Wyatt-Harding, Dr. Duncan, and Janelle Williams. And it was a volunteer-led effort. We did this project without any funding and really just committing our time and our skill set to moving it forward. The specific objectives determine the key challenges and coping needs of individuals living with lupus, identify barriers and facilitators to accessing lupus care, identify the perceived role of peer support volunteers, determine preference for the delivery of the peer support program, and gather comprehensive information on the educational topics and skills that stakeholders believe should be included in the peer support training program. So our target sample, we wanted to recruit, based on our analysis, 236 individuals were living with lupus, 40 healthcare providers, 59 caregivers, and it was mixed method, so we had a quantitative survey, electronic survey. It's around 7 to 9 minutes. And if anyone in here who has not done this, if you actually point your camera at the QR codes, if you are someone living with lupus, if you provide health care, your physician, any professional, provide health services, or a caregiver, and you can actually do the survey after I finish presenting. I don't see any phones. Thank you. We still need participants. It's ongoing. It will come back at the end. Thank you. All right. That was too quick. It will come back in the end here. I don't want you to be distracted, so look out for it. All right, so we were able to, guys, I struggle with technology. Of the target for 236 persons, we were able to recruit 87. And for several reasons. This was really primarily between late January and March, where most of this data came in, and then probably a handful, like another 6 to 10 came in May and April, May. We had 12 caregivers who did the survey and 20 practitioners, so nurses, physicians, I believe social worker who supported persons with lupus. We also completed some individual interviews and were able to organize and complete one focus group session. Can you guys see it? Okay, yes. So for today, I'm going to focus on the patient survey. We have 20 minutes and it's a lot of data and it's still being processed. So instead of trying to cover the 3 surveys and go in depth with the qualitative, I'm just going to give you a sense of what we're seeing from the persons who are living with lupus, and also provide some context with some of the quotes and some of the themes that we saw in the interviews as well. So most of our participants were all between 18 and 73 with a mean age of 40, primarily female, which is in line with the distribution of lupus in the population. We had 82 women and 5 men completing the survey. Most were university educated, so over 56%, 17% high school grads, 15% had vocational or technical training. Most were single, Never married, 23% married, 13% in a visiting relationship. 55% were employed full-time, 10% self-employed, 8% part-time employed, and the rest were students or unemployed or retired. The total monthly household income was below, half of the participants were below $250,000 per month. 32% lived with family, 24% lived alone. I think it was like 19% lived with a partner or a spouse, and then another 11%, I believe, lived with children. In terms of residents, we had participants responding from every parish except Hanover. So we were able to capture a good sample. And it was, like I said, electronic, so the link was shared throughout the different networks and at some clinics, so I know at KPH, and I wish Dr. Tullereed was here, there was some other in-person collection at other clinics with a tablet, as well as also at LFJ. So in line with our population distribution, most of the participants were from Sierra, so that's KSA, St. Thomas, St. Catherine. 13% was from the southern region, Clarendon, Manchester, St. Elizabeth. 17% from Western, so Westmoreland, Trelawney, and St. James, and 14% from Northeast, St. Anne's, Portland, and St. Mary. So it's, really in line, but one of the things to flag, I think it was like 70% came from 3 parishes, which was KSA, St. Catherine, and St. James. So really there was a concentration with where the participants came from, but we had at least 1 or 2 or, less than 10 in most of the other parishes. So that's who was in there. So the 5 objectives. First, key challenges and coping needs of individuals living with lupus, the pill burden. So this stood out in this survey, and as well when we went into the individual interviews and the focus group. Persons, one person said, "It's a cup of pill me take a daytime." It's a lot of pills, right? 50% were taking 5 or more different medications. The most common one being reported was prednisone. I can't pronounce some of these because I'm a psychologist. Hydroxychloroquine. You hear that? Yay. Vitamins, I know this one, or supplements, stomach medication, and pain relievers. These are the most common ones being reported by persons in the study. 66% reported that they've had side effect from a medication, and 55% they have discontinued medications because of the side effects. So I just did a little word cloud with this. The big word, hydroxychloroquine, was the most common one that they said they discontinued because of side effects. Prednisone, methotrexate, and then mycophenolate. So these were the ones that most persons said they had to stop. I have a quote in here. At one point, prednisone, I discontinued prednisone because it pushed out all of the acne on my face. I was then on methotrexate, where I was having heart problems and seeing blood in my stools. So the side effects is not just one thing. Sometimes someone will start something else and they have other side effects. What patients also reported that they're taking pills to combat side effects of other pills, and then those give them side effects. So one young person in the focus group said the stomach pills that you get to help coat your stomach because of all the pills you take, and she's like, I don't take the stomach pill because it makes your belly big and stiff. And as a younger person, on top of all the other things and body issues, yeah. Main symptoms experienced in the last 3 months, fatigue, joint pain were reported by 70% and 65% of the persons in the sample, and 50% reported forgetfulness. The other ones are around emotional things, so depression, anxiety, muscle pain, 48, so nearly half of the participants. Muscle weakness was another 45%, joint swelling, unusual headaches, shortness of breath, So that was at least, more than 1 in 3 persons reported experiencing those. Which of the symptoms had the most significant impact on your daily life? Fatigue, yeah. So the fatigue and the joint pain dominated daily life. And living with that also then caused, and muscle pain, that was 48%. Experiencing those things at that level also, then in the focus group and the interviews, you heard the emotional impact coming from that, living it with the pain and the tiredness, and it's beyond tiredness, the fatigue, and how that affected them emotionally and the impact that had on work. So one person was saying, the lack of energy, this is the thing that bothered her most. And persons, who don't understand it, they think that you're lazy. And I used to be an active person, but now it's like my mind wants me to get up, but the body is saying, no, just lie down. And this affected jobs. This person was self-employed, and so she wanted to get out of bed because she wanted to go open her business because she needed her income, but her body said no. And so, this was heard throughout the different interviews. We also included in the survey the patient health questionnaire, very brief screener, literally 4 questions, but it's standardized and is a valid indicator of the presence of depression and anxiety symptoms. 33%, so 1 in 3 persons had no significant symptoms of anxiety. However, towards the bottom, 18% had moderate anxiety or depression symptoms, and 5.7% severe anxiety or depression symptoms. So, take that alongside the previous slide. Emotional issues are a significant burden for the population, and at severe levels where it will affect functioning. Lupus, for most persons, it doesn't appear in isolation. There are other chronic illnesses. Only 28% of the participants said they didn't have any other diagnosed health condition. 25% said they were diagnosed with high blood pressure, 20% with high blood cholesterol. We had sleep disorders, kidney disease at 10%, and osteoarthritis at 9%. And other was 24.4%. And some of the other, the ones that came up most frequently, rheumatoid arthritis, fibromyalgia, were the 2 strong ones in terms of other diagnosis. Barriers and facilitators to accessing lupus care. The delay. So one of our participants in the focus group, every single person we spoke to said that they had a hard time getting diagnosed. In the survey, it was an average 5-year between when they first had a symptom and when they got a formal diagnosis. When you listen to how it was described, this delay was so much more than time. It was the emotional and the psychological burden that came with that. One of the participants said, you never go to the first doctor and they say, yeah, you have lupus. Never, ever. Persons talked about going to multiple doctor visits, multiple tests, being given diagnosis without any serious investigation, or just feeling like they weren't taken seriously because so many of the symptoms that they had were invisible and non-specific. And I think in one of the focus groups, the one focus group we actually had, as we're going through it, it was so clear, like everyone's initial presentation was so different that we were saying, well, we understand why the doctors might have a hard time pinning down that diagnosis because persons come in with so many different signs and symptoms that could be attributed to some other diagnosis. So this gap, lots of challenges happening in there, and then other issues and barriers to them getting the care they needed was a cost. So whether it was a cost of the medications, and one of the persons with a question earlier, they mentioned having lupus is an expensive disease. The cost of different tests, the cost to have your specialist, to visit specialists. Then there are other costs around the transportation. If you're traveling to a specialist in Kingston or in St. James, and the time, the effort, the income that you lose, and the bills that you're going to incur to do that. the long wait times when you're referred for a specialist appointment, it can be months. And if you don't have someone advocating for you in the system, you might not get that expedited. Treatment literacy also came up. We have a treatment literacy scale in the survey, and 40% reported that they found written medical information difficult to understand. And so this affects following through on referrals, adhering to your treatment plan, adhering to your medications. And these are all issues that come back around when we think about what roles peer support persons can play for persons with lupus. What were some of the facilitators? Finding a caring or knowledgeable doctor or healthcare provider. So we talked about that 5-year gap on average where persons are all over the place trying to figure out what is this that I'm experiencing. And this person said, when I finally met a doctor that really listened, everything changed. She explained things properly and tell me what to do. And you know, one of the key things these doctors that came to their rescue, nurse or whoever the healthcare person was, they linked them to one of the sites or to someone who specialized in managing lupus, so public health or privately, and they also linked them to LFJ. And persons, I think through all the interviews, talked about the role that LFJ played in helping to access to peers, to other persons who could share and understand what they were going through, and also the resource to understand and get knowledge about the diagnosis. So someone said, if I never joined the foundation group, I wouldn't know nothing about how to manage. And this was a common theme. Self-management or empowerment, this is where I think it really came together. This is one of the outcomes you want to have with a patient, where they're able to understand and really manage their treatment and contribute to their overall improvements. So this person talked about when they really understood the disease and understand the value or the importance of them being involved, they change. And you know, when my body starts to act up now, I write down my symptoms and I show that to the doctor. So they come into the clinical visit, clinical encounter as an active participant. And that helped them to, you know, do much better and have better outcomes. Family support was also important. So assisting with transport costs and just supporting them emotionally. My mother and my daughter always come with me when I have to go to hospital. So this person doesn't have to go alone. Perceived role of peer support volunteers. These 78% of the persons said they felt they had good social support systems, but there was a gap in terms of just how dynamic or fluid symptoms were within the course of a day. There were so many things that someone without lupus just didn't understand that they were experiencing. And 61% said, yeah, I would like to get some peer support. After we described what the idea was in terms of having someone with lupus who would be there to work with them and meet with them on a regular basis, the main things that persons said they would want from a peer support program: the emotional support and empathy. Sometimes you just need somebody who knows how it feels. They also wanted information and health navigation, how to, they will referral them, help me know who to ask, nutritionist, social worker, or some other specialists that help them to sort of digest all the information that's coming at them as they're going to their clinics. Practical support and encouragement. So someone who's been through it or is also managing it and doing well can help them by, you know, giving them some practical tips and motivation. So someone said, if just to check on you, if I get a call every now and then, that helps to keep me going. Self-care and wellness. So share some practical tips on how to manage, like how do you manage your flares? How do you know what routines to lean into? How do you manage sleep, your diets, the timing of your different medication? Those are things that persons would want someone with more experience or who is doing more successful at it to share that with them so that they can tweak their own approach to it. Empowerment and education, so help them to build their own confidence and how to advocate for themselves as they navigate the health system. So share your story of how you overcome so that I can learn. This came out a lot, like one of the things, that 5-year gap, one of the things that came out was when persons finally got a diagnosis, so many of them just felt like they didn't get good information, or they were met with very morbid declarations of, sharing stories of persons they knew who had lupus who died. Like when you just get a diagnosis, that's not the first thing you want to hear, right? And those are the things that quite a few persons said they heard. And then no one in their family knew about it. And so, and they didn't know, so there was just nowhere to turn for education. So they really wanted this kind of empowerment and sharing and support from a peer support person to help them sort of chart the way in their own personal lives. And then community, strengthen social connections, reduce stigma. When we come a meeting and hear people talk, we feel that we can manage. So something about the sharing helps to strengthen them. Preferences for delivery of the program. Hybrid, so combine online or in person, or online were the two most popular options. And this makes sense because these allow flexibility. Because you never know, and I learned this throughout the process, because you are all set to go to the meeting, but then as the day progresses, your fatigue sets in, or your muscle pain or joint pain sets in, and you can't go. But you could log in online, right? And so flexibility was so important. And as we're doing the Zoom calls or the in-person meetings, I saw that in real time, where persons who were scheduled were like, Doc Art, I can't do it. And I was like, I'm flexible. I got it really quickly. And we rescheduled. And so for the program, that kind of flexibility has to be considered. And so it really needs to be hybrid or online fully. Telephone was least preferred option, and in-person only was at 1 in 4 persons. Frequency, once a month. But again, the flexibility part. Persons wanted you to check in, like still call me between the scheduled meetings to see how I'm doing. That call sometimes will come at the right time when I'm low, and it will make such a difference. So they wanted that kind of contact, even if they didn't want to meet so often. So flexibility, big part. Small groups is good because they want the community, but you also need one-on-one, because some sensitive issues that you might want to discuss. Some of the questions persons said, they had was around like fertility, sex, sexuality. We had the males, they had some very male-specific concerns, and they questioned whether men would show up at support groups if it's really one man and 8 women in the group. And so you needed to have that kind of flexibility where, for me to benefit from the peer support, it must be the type of support that I want. And then the regular check-ins in between our standard scheduled meetings. The topics that they recommend, so there are 2 areas. What are the skills that we need to train the peer support workers in? And then what are the topics that the peer supporters should be versed and able to provide guidance on? So what are the core skills? They must understand essential core principles. So what the role is. Like as a peer supporter, you're not a doctor, you're not a psychologist, but this is your role to help your peer navigate by sharing your lived experience and lessons from it and being a supportive peer to them. Understand confidentiality, understand boundaries in that relationship. So these were key things for the curriculum. Communication and active listening, they want you to listen. Yes, you're gonna share from your experience, but you're going to listen to their experience, and then your contribution needs to be relevant to what they're sharing. The empathy, that was such a big part for them, and the idea of having this invisible illness for the some of the fatigue, which was the most common one, or the pain, and so someone will see you looking fine. One of the examples a few persons kind of resonated with was someone was saying, like, I was so sick, but they were started on prednisone, and so their face got fat. And everybody was like, oh, you look so good, you look rosy. And they're like, oh, geez, if only you knew. So there's this disconnect between how they're feeling and how you look and what people are saying, and then you can't explain it because then people just think you're making it up because you were fine 2 hours ago. What happened? So the empathy and having someone who understands and can, sort of they felt what you felt and they've experienced it and can empathize with you. They also wanted to ensure that the curriculum covered mental health issues, and it's come up in the previous presentations around just the emotional and the psychological aspect of the disease. So we need to recognize the stress, offer support, and in terms of the role, the peer supporter, they're not a counselor, they're not a psychologist, so the LFJ will need to have a mechanism in place for referrals so that we can make referrals to professional help as persons are screened and identified, or as persons share certain trigger information. Peer support must know this person needs to go talk to somebody who can screen and give them the help they need. And then to navigate the system, so the referral, there's so many specialists you might need to see, and the NHF, how to make sure you're registered and accessing the available benefits from NHF, and how to get into the clinics, and if you need to go to a different clinic at a different site, how to do that. So having support around that would be helpful. So I feel like I've definitely gone over my time, but that is the last slide. And a lie. Did I miss something? How you go back? That was, oh yeah, so then there's things they needed to train, sorry. Managing the illness, peer supporters must be educated on helping them understand lupus, cope with the pill burden, side effects, the mental health, healthy living, navigating care and self-advocacy, social support and relationships, reducing isolation. A number of persons talked about isolating, refusing to be in relationships with persons because of lupus. And then male-specific concerns and experiencing, one of our men talked about men with lupus, they're rare. You don't see them frequently. Going to a doctor with a male-specific issue, and the doctor didn't know how to proceed because they didn't know if the treatment option was indicated for someone with lupus, and so the two of them were there, not clear where to go. So having resources where you can refer persons, so like a list of providers to know that if you're a man with lupus and you need urology, say urology because that's very specific, here are some urologists who are familiar with patients with lupus, and this is a good person to ask your doctor about referring you to. So those kind of issues came up as wanting to be able to talk to their peers about and access those resources. And then coping for persons who are newly diagnosed, because that's where you're trying to wade through everything and you're hearing all the doom and gloom. No one has any knowledge on it. And the things that are being shared with you are just around the worst possible outcomes. So ensure that, the peer supporters are able to share some specific information for someone who's newly diagnosed. That really was the last one. All right, so next steps. Like I said, it's preliminary. We have a target for 236. We had some issues with getting into some other sites, but I think we're almost there now. And if you're in the room, you can help us get through the finish line. So we want to complete the data collection. The curriculum is being drafted as we go along. So we need to finalize that curriculum so that we can start training, because it is clear from the data that persons look forward to having trained peer support persons that they can be connected with. They have some very specific needs that they would love to have the support around, and they would benefit from support around. And so, we do want to move forward with this piece. I see cameras up, so say thank you, all persons, to the survey. I hope the link working. The link working, right? Don't double do it. I heard someone say, I think I do it already. Oh no. All right. Moderator, I'm really done. Oh no, the next one is not even coming. I feel like the next slide was my thank you slide, but they paused it, which was just a thank LFJ volunteers and staff, Lupus warriors, caregiver, healthcare providers, and then a data team who helped us to process a lot of data, quantitative and qualitative. So I just want to thank everyone.
Thank you. You're welcome. She's going for water. We're now down to our question and answer segment. But before we go there, we just want to say at Lupus Foundation, we have a social worker and counselors there who are able to assist our members. So persons who are online, remember to join the foundation, and you can go to our website at it's lupusfoundationjamaica.org/member benefits. Anyone with questions for our researcher?
Under the survey, the impact of lupus and perimenopause and menopause, I think probably that's something that needs to be incorporated into the peer support, and also financial retirement planning, because most of us are ill, and usually by the time we reach retirement, we don't have no funds to retire on. So that's something also that probably needs to be incorporated under the research.
Yes.
Thanks for that point. We do ask in the qualitative interview when we're asking, what are the topics to cover? We do ask, how about gender-specific topics, stage of life, age-specific, and rural, urban. So we try to get feedback in those specific areas. So it's preliminary, it's a lot of data. So the qualitative ones we haven't looked through fully as yet. So as I'm going through it, I'll definitely pay attention to see if that's come up. Just thinking in terms of recalling the interviews that I did, I don't think anyone specifically mentioned it. But as a woman of that age myself, I'm thinking that people might not even recognize which symptoms are perimenopause or menopause versus what's the lupus, right? Because when you think, I'll tell you a joke, for the last 5 years, I've been telling people I have long COVID. Because I was in denial that it could be. It's about a denial now. But when you think of the symptoms, it's that fatigue, the brain fog, the anxiety, they overlap. And so persons might not even see, but we might see where the rates are higher, the experience are more intense if we look closely at women in that age group. But yeah.
Anybody else have a question? Oh, Ms. Abiomi is at the back.
Good afternoon, everyone.
Good afternoon.
Thanks for your presentation. One of the things that I want to ask is that the researchers, did you try to go to let me start from here. I know at least there are some persons that are teachers that are presently lupus warriors within the primary school. Did you go around to check some schools to see so that they can get some data from them? That is probably primary schools or secondary schools so that you can add to your data. That is one. The next one is that in terms of our colleges, teachers' colleges and university, the team gets to go around to publicize this research, because even sometimes some of these our so-called young ones at the colleges, they are going through this condition and they might not want to come out, but at least if there's some awareness that this research is going on, probably that will give you more sense of data. So I'm not sure this data you present to us, where they come from. So that's why I'm just asking.
No. It's a really good point. So I said it was recruited mainly through the mailing list. So the persons already engaged with LFJ.
Okay.
So whatever the mailing lists are, and then also in lupus clinics. But the survey has also been shared on social media and would have been boosted, so persons could have come across it there and also participated. You make a really good point, though, about persons in universities and in high schools going through it. And one of our participants in one of our interviews made the specific point that one of the outreach and educational efforts that LFJ should prioritize is actually doing awareness in these spaces, because again, you remember the gap between symptom and diagnosis, because there's so many young people in university and in schools who are suffering with lupus, but they actually don't know what they have and they haven't been diagnosed as yet. So that's a recommendation coming out of the data we have, which aligns with exactly what you just said. In terms of widening where we're getting the data from, it's something that we have to do because we need more persons. So it's who from LFJ, which volunteers are able to access schools, teachers, colleges who can share the link to the survey, and then we can have persons who are not in LFJ network, but who are out there would be willing to participate. They'll have access to it. So thank you.
Okay, so I'm just, as I said, that let us just look what in a broader sense rather than just LFJ communication email list alone.
Yeah,
because
agreed.
If we get a lot, it will give us more things that is happening out there.
Yeah,
thank you.
For your research, and that session was so emotional for me as a lupus patient, because I went through all of those. I'm currently still going through on a daily basis, especially the fatigue and the forgetfulness. So we thank you for your research and as it is ongoing, because it really affects us every single day and it's hard. Yeah. All right, thank you. Come on to the presentation. Miss, we will have a presentation for you from Miss Anishka. Right there. Yes.
I was a part of the interview and it was very impactful, and I share the same thing when you were speaking. All right. So, I'll say, all right. So thank you, Dr. Jarrett. Right. As I was sharing that, I was a part of the research, and I must say, when she was sharing it, brought back some emotions, because in the beginning of when you're getting, your diagnosis and you're going back and forth, and you really don't know what is happening to you, it can be frightening, right? So we really do appreciate this patient-centered research, and I know that this peer support will be very impactful because, as I said, when you're just diagnosed, it can be a little bit stressful. So thank you very much for yourself and the other volunteers who have dedicated their time to doing this. And we hope you appreciate this token on behalf of the foundation. Right. Oh, sorry. Right. I'm trying to give it. I don't think I'm not used to it.
All right, Miss Anishka Stewart, who is also a board member, lupus patient also. She will be sharing the Patient Voices video with coping with lupus and skin disease.
Right, so good afternoon, everyone. As you heard, my name is Anishka Stewart, right? And I volunteer as well as I'm currently a board member with the Lupus Foundation of Jamaica. I also happen to be one of the many people living with lupus. Yes, I'm not just a part of the foundation, but a part of the research sample too, right? For those of us living with lupus, the effects are not just physical. When lupus shows up on our skin, it can change the way that we see ourselves, and sadly, how others see us too. People stare. People sometimes ask some very creative questions, right? And they don't see past the rash, right? And trust me, if the stares could heal us when we say that we have lupus, boy, it would have healed a long time. Because they're just like, oh, but you look so fine. But here's the other side. I've also experienced love, support, and growth. And that's what today is about. Not just the medical side of things, but the emotional and the social toll. And more importantly, how all of us can help to create a more supportive and inclusive society, right? Before we dive into our panel discussion, we'd like to share a short video from our Patient Perspective series. In this segment, you'll hear directly how persons living with lupus, as they speak up honestly about their journey with skin involvement and the impact on their confidence, relationship, and daily lives. These voices behind the statistics, these are the voices behind the statistics, sorry. We're grateful to those who bravely shared their stories. So let's take a moment to watch and listen with compassion and openness.
My name is Marjorie Allen, and I have lupus from about some years ago. I'm not quite sure the exact year, but it's about 20 years now. And it has been an uphill, up and down journey. Sometimes, even though it is the skin one I have, it's still, you still have the pain like what others do, and you still have the pain and the weakness and all that goes along with it.
My name is Claudette Hobbins. I am 69 years old. I've had lupus from 1982, and the journey has been up and down, as lupus is, as it affects different areas at different times. I have systemic lupus, so I have different organs affected at different times, and some a little stronger than some. Yeah, that's me.
Hi,
Hi, my name is Emily Elliott. I am a Kingston-based music teacher and musician, and I was diagnosed with lupus in April 2006. It started off with hair loss, and that has been the main issue, along with skin lesions, the scarring, throughout my journey since then. It's been a roller coaster ride, I would say. There have been some very, very severe flares where it has developed to what you see today, and then there have been some very calm moments where I'm able to just exist as normally as possible. So yeah, I give thanks that it's only my skin that it has really severely affected.
I first had like a scar or a rash over my eyelid. And although I'd gone to many, I work with primary care, so I'd gone to many physicians there, and they're giving me steroids and so on, but nothing was really curing or stopping or preventing it. So I asked for a referral to University Hospital, a skin clinic, where by that time now I had rashes in my head, and they did a biopsy. And coming out from the biopsy, they recognized that I had systemic lupus at the time.
So when I was in university, I was in my second year of university at UMUNO, and I had locks. They were really long, like down to the middle of my back, and one fell out. I just realized that there was a space and there was no hair there. And when I touched that spot, it was very tender, and it had like a dark circle. So that was very concerning because it's something that had never happened to me before. My hair was always strong. So I went to a dermatologist, had a biopsy done, and it was immediately confirmed that I had lupus. And the dermatologist at the time kind of took it lightly and said, oh, well, it's just one spot. It's not like it's your whole head of hair. But I still had to go and see a rheumatologist and start with treatments. In about 2008, far more hair loss started to occur, where I had several patches going. I had so much hair that it wasn't that obvious, so I could always cover it up or style a certain way that it wasn't seen. But after a while, it was really, really difficult to do that, and really distressing to take a shower or wash my hair or just simply scratch my head and a lock just falls out. So that was a very, very hard time, just to see all of that hair loss happening gradually. And so I decided to just cut off what was left of my locks. So I've been rocking short hair ever since.
When I went to the
All right, so the final session brings together some powerful voices from doctors, medical experts, and of course, a lupus warrior, to talk about what needs to change and how we can be a part of the solution. It's my pleasure to now introduce our moderator for this session, Dr. Raquel Lowe-Jones, our board director for programs at the Lupus Foundation of Jamaica.
Thank you so much, Anishka, for that introduction. And I just want to say we made it to the afternoon. And after that segment on patient voices, I mean, it's something, that's the main reason why we're here. For our patients, to empower them, to support them, and to advocate for them. This last segment is very, very interesting because we're going to tie in everything we heard today. The medical aspect, the patient voice, the patient's perspective. This final segment is the impact of skin lupus, the physical, the psychosocial, and support. I'm hoping that we had a good amount of learning today, And I just want to put a plug for the Lupus Foundation of Jamaica that this session was free of cost to all our lupus warriors and to the public. You know, one of the foundation's core values is to encourage and support persons with lupus. As you can see around the hall and outside, we have a QR code because this could not be all possible without support and financial support from sponsors that are here today, as well as private and public donors. We encourage you all to make your tax-free donation and to also support with purchase of merchandise, which is in the back. So without further ado, I'd like to invite our panelists to the front, Mrs. Emily Elliott, Dr. Javila Ho, Dr. Romario Thomas, and Dr. Stacy Davis. As you heard, Ms. Elliott is a musician, and we were very pleased to hear your musical rendition. Dr. Javila Ho is a licensed associate clinical psychologist with over 15 years of experience in clinical psychology across both the public and private settings in Kingston. She's a senior associate at KAD Morgan Associates, where her work focuses on adults navigating trauma and stress-related conditions, including personality, grief, mood, and anxiety disorders. Her clinical approach is integrative, trauma-informed, and culturally sensitive with a strong commitment to delivering effective client-centered care. We heard from Dr. Thomas earlier, who gave us a very excellent rendition and cohesive talk on the cosmeceuticals and the impact of that on the emotional development of our lupus patients. And lastly on our panel is our doctor, Dr. Stacy Davis. She's a board-certified adult rheumatologist in Kingston, Jamaica. She earned her medical degree from the University of the West Indies and later completed her internal medicine residency at Carilion Clinic at the University of Virginia. She's an international fellow of the American College of Rheumatology and the current secretary of the Caribbean Association of Rheumatology. She's also a past president of the Lupus Foundation of Jamaica. So get ready for a great panel discussion. So, we'll begin with Miss Emily. Thank you so much for your musical rendition and your testimony earlier.
You're welcome, thank you.
How has music inspired you through your journey with lupus?
Good afternoon again, and thank you so much for having me. Music has definitely, I think, saved my life in so many ways. I think for all of us, we can relate to just, having that particular song or that particular genre that just calms us and helps us to see more of the positive when there can be so much negativity surrounding us. And it's helpful that I also work in music and I work with children, so there's a little less of the stresses of the corporate world or what the corporate world can cause. I'm also blessed to be in a family business where I can plan my schedule and do things based on how I'm feeling. Thankfully, I haven't had to take any extra time off work, but as a teacher, I do get those breaks. So I know that's not just music alone, but the fact that it is the music industry and it is a co-curricular job that I do have, I'm able to work and work in a way that helps me to balance with living with lupus. And also sharing music really helps me.
Thank you for that. Dr. Davis.
Afternoon, everyone. So I was asked to speak on the role of the healthcare professional in the well-being of the lupus patient outside of the clinic. And if I'd use one word to describe it, it's really that we're supposed to be co-navigators, right? We need to walk with you along the journey. And a lot of this co-navigation really relies on the concept of co-creativity. And that's anchored in individuals of different disciplines and specialties working together collaboratively in order to develop solutions and understand a shared goal, right? And that shared goal is achieving individualized, patient-centered care. So all of us as healthcare professionals, we are well-trained in evidence-based medicine. We know we have accurate knowledge that we use to come up with a diagnosis, and we use it to treat you. So we're supposed to improve how you feel physically, and we're supposed to reach targets. There are certain targets we want to reach. But the truth is that patient care and well-being in a patient requires a lot more than that, right? And one of the things we need to do with the knowledge that we have is actually to share it with our patients, right? Because we know patients who have good knowledge have good self-management skills, and it impacts their outcomes positively. The other thing we need to understand is that many patients want to be told accurate information because there's a lot of mis and disinformation out there. And if I was to illustrate this point, I'd use this study, the results of a cross-sectional online survey study done in Germany in 2021. And the study was aimed at identifying the unmet information needs of patients with rheumatic diseases and also to inform the development of a mobile education application. And they had 254 patient responses. And the three most important, highly rated topics were that the patients wanted information on their individual disease, the patients wanted medication information. They wanted to understand what is this thing that they're putting into their bodies every day. How is it going to help them? How is it going to harm them? And then the third thing that patients, the third rated thing at 91% of respondents, putting this as the third most important thing, was coping techniques. So we say that coping, being able to cope with an illness, that support is as high up there as the science of medicine, right? And the first thing we have to do as healthcare providers is to show empathy to our patients. That's the starting point. They value it, and it shows that how they feel and what they are perceiving matters, right? So you become listener-in-chief, right? And then listener-in-chief moves on to, after validating and understanding and reassuring, to the coordinator-in-chief, basically. Because outside of the medical specialists that you rely on, you're going to have to now be the person to direct patients to non-medical or allied healthcare workers who can help them. So we know the psychotherapist is extremely important when it comes to cutaneous lupus, because apart from the physical difficulties and distress, as we said earlier, this is an area of lupus where you lose your privacy. Everybody sees what's happening to you. And we live in societies where how you look matters, right? So how do we do this? We have to collaborate. And really, we should try to have a network of persons that we know have similar interests or expertise so that we can readily direct the right patient to the right specialist. We also have to remember that apart from psychotherapists, there are lots of other allied workers that can help. We have to remember that nutritionists can help. If you don't have the right nutrients, you won't have your skin heal. Even physiotherapists, they can look for breakdown of skin. They can help with circulatory problems. So all of this means that listening to the patient leads to what they need. That whole concept of patient-centered care and shared decision-making. So we always have to remember to ask the patient, what is most important to you, right? We also have to manage expectations because we have to always give hope, but we have to remember that we have to guardedly give it. We have to say to the patient, guess what? This can help you, but it may take 3 to 6 months to work. So they understand what they're up against and they don't get discouraged along the way. Other things that we can help with is certainly advocating for patients in terms of pharmacy. Overlapping, as Dr. Romaria said, we need to bring other things in that help with how the patient feels. We need to bring in the government, policy makers, in understanding the importance of skin matters. Because for some people, they're going to think, oh, it's not a big deal. It's not your heart. It's not your kidneys. But the holistic approach to the patient requires us to recognize how important an impact this condition has.
Thank you very much for bringing that aspect, the whole person. Dr. Ho, can you speak up on the emotional toll of skin disease and lupus and addressing that whole person concept? How can mental health services help? And what role can caregivers and communities play in that psychosocial support?
Sure. Thank you. Thank you for having me as well. And thank you for considering the holistic person and inviting a psychologist to be a part of the discourse here today. And I think, as we speak about cutaneous lupus and this physical manifestation on the skin, I think it's important when we're thinking about maybe stigma, because a lot of talk has happened around stigma, that we also consider what internalized stigma is and how it happens with persons who have skin conditions. And internalized stigma, for those who are not very familiar with that particular terminology, is when we apply the negative stereotypes that others may have to ourselves. So typically it starts off with awareness. So we know people may have a negative stereotype of a particular skin manifestation. And, that's the typical type of stigma that we're discussing. We are aware that others have this perception, but we don't necessarily think that's about ourselves based on our own knowledge or our lived experience. But then it moves a step further. We also agree with that negative stereotype. So we believe it to be true. And then we lastly apply it to ourselves, which means that we start to engage in that negative self-talk. We start to believe that maybe we are not worthy of being in particular groups and associations. Dr. Jarrett very recently just mentioned, that social isolation. People were just reluctant to be involved in relationships or to go into social settings simply because of their own awareness and maybe their own beliefs in these negative stereotypes about the skin manifestations of lupus that they were having. And so you can imagine, of course, that with all of that negative self-talk and that negative self-perception, how that impacts self-esteem, self-confidence, how persons may show up or not show up to work, and for our younger persons, maybe to school and to class and certain, public-facing experiences, which means that they're reducing, by default, the amount of social support that they could potentially receive. Right? And sure, there are some circles where they aren't getting a lot of social support, but the possibility exists when we are in a group or in a community. There's also, of course, higher risk for depression and anxiety. Right? We'll see higher rates of depression and anxiety with persons who experience any sort of visual or visible skin disease. And so, again, we think about persons who are experiencing, we heard Emily kindly share her own testimony about how this impacted her during her time at university. And I think we grossly underestimate the impact of the change in our physical appearance and how that can really impact us emotionally and our self-perception and how it is that we start to navigate and experience the world. A lot of us, if you've never experienced it, the degree of severity that persons living with lupus have experienced it, I think we don't really appreciate how impactful that can be on our self-esteem. And so it is important to also have community and connection with persons with lived experience to really get a better sense of that. And so mental health services, just to answer your question more directly, mental health services help to address not just the external stigma that people may be experiencing, but a lot of that internalized stigma, combating a lot of those negative self-beliefs and self-talk that persons may be having, identifying the areas in which they may not have social support. Maybe it is that they are not aware of the medical resources that could be available. I heard earlier as well about just treatment literacy. Some persons are dealing with a lot of mental health conditions because of their medical condition, simply because they don't have a full understanding of what it is that they are dealing with and the treatment and the resources that are available to them. And sometimes it's through the mental health practitioner that we may help to connect them to some of those persons or to some of those practitioners through the Lupus Foundation as well. I know personally that we have had that connection and that collaboration to provide this counseling services to lupus patients. But then also we can offer some of those behavioral activities. Again, if they are being more socially isolated and a lot more withdrawn, what are some of those spaces that there are activities that you previously enjoyed doing that you've stopped doing because of how you're feeling about what you look like? And how can we help you to re-engage some of those? A lot of times it's also understanding and accepting that there have to be adaptations to that, right? We spoke about, I know some of our speakers earlier spoke about sunscreen and the protective wear. Maybe there are things that you used to wear that you can no longer wear. And again, we take it for granted that that is an important thing to us. We want to wear what we want to wear. We want to look a particular way. And because of some of these skin manifestations and the way in which we have to protect our skin to prevent certain, flare-ups and exacerbation of symptoms, we have to dress differently. How is it that we help people to adjust to those changes, those lifestyle changes that they have to take? And how do we help them to become comfortable with that and have a life that they feel is meaningful and still full and thriving without necessarily having some of the disadvantages of depression, anxiety, and learning how to cope with some of those experiences.
Thank you very much for that. Our last panelist, Dr. Thomas, can you give us a little talk on managing skin involvement in lupus, especially about clinicians better educating patients on treatments that are available, and more importantly, the safety of those treatments that are offered? And the patient's expectations, because you prescribe a medication or treatment and they expect that the scarring or the physical appearance will improve.
Yes, definitely. So each of those, in that schematic, each pillar has to do their part. And I think it starts with the providers in terms of arming ourselves with the information, arming ourselves with the data. We know that, as a medical provider, we have to do our courses and our CMEs and stuff like that. But for persons especially dealing with chronic issues like lupus, where, again, it's not just internal but also very face forward, we have to ensure that we educate ourselves so that we can speak to our patients about, what are the expected results on these medications. Again, we're aiming for gradual progress and not perfection. What is the evidence showing? And even if the evidence is showing this, what are your individualized goals? We have to ensure that we talk to each patient, not as, a data set or okay, this is what the results will show. I love the form of medicine, and it's probably one of the reasons I delved into cosmetics as well, because each patient is so individualized. So when we see our patients with skin lupus, with these conditions, even if you have the same diagnosis, it may not affect you the same. Mm-hmm. Somebody with hair loss, shave off that head, I'm good to road. While somebody losing a lock of hair when you're a Rasta with, a full proud mane of hair is devastating. So we have to individualize how we see the patients, how we talk to the patients, see how different things impact them, and then know we can apply the science to that. What are the methods that are most suited for you? Are we going to try and go with camouflage? Are we going to try and go with intralesional steroid injections? Are we going to try, hair transplant when your disease is not active? So what I'm saying in totality is that it brings a lot on. I think the patients have so much dealing with. I think we as a provider are the ones who need to make that extra step to make ourselves better. To make ourselves better able to communicate, to make ourselves better able to empower, to make ourselves better able to diagnose and deliver, old and new cutting edge modalities to our patients. and to be very inclusive, as we've all talked about today, in how we manage the patient. It is not only about the internal, it's not only about the external, but seeing each patient as, someone, putting yourself in their shoe, and then, being able to impart the right amount of solid care to the aesthetic as well as the medical component of the patients.
So true, so true. At the end of the day, it's really about the whole person, internal, external, the entire person. At this time, this concludes our short panel discussion, and I'd love to field some questions from the audience, as well as from our online audience. Any questions from online?
Afternoon again, everyone. Thanks for the enriched and also powerful panelists. I'm here on behalf of the foundation, being the past chair for service, and we normally have our support group meeting. We have in the Western, and then we have here in Kingston. I'm just pleading at this moment. Is a plea I'm pleading on behalf of our warriors that I would like to reach out to this panelist again. It's going to be online because some of our warriors are not here, but as a support group meeting that we normally get in touch with each other, that if we can reach out to you, this panelist, and we don't mind to add on to it because some of the warriors, as some of the presentations come about, it's difficult for them to come out. It's not in terms of they don't want to come out. Sometimes financial, sometimes emotional, and so many things. But if we can get this panelist as one of our support group meetings, and they can easily reach out by explaining themselves, and then they get somebody to talk. I know that we have this live talk by physicians, but it cannot difficult to probably for them to reach out. But if we can ask on behalf of FLG and the warriors that if we reach out to you, it don't have to be this October, and it don't have to be December either. We can do it fresh if we can reach out to you. That please, on behalf of the service committee, the support group meeting coordinators, we'd like you to please help us again. It will reach a long way when we can have you as a group. Thank you.
Thank you. I'm sure that can be arranged, that our esteemed panelists can be a guest speaker at one of our support group meetings. It's normally in the evenings, once a month. So I'm sure that can be arranged.
And what we could add is, one of the things that, one of my approach to, how I do medicine is to be very interactive and to be in the know and do what's going on. So social media has given us so much power in terms of reach and access. And it's a fight you can't fight it. You understand? And all the lupus warriors, all the patients, stuff like that, okay, we're not gonna argue with TikTok. Let's use TikTok and those things like that. I mean, a TikTok live stream is it's very easy to join. And instead of using it for laughs and giggles and negativity, we can use these platforms to reach our patients. So even if it's kind of hard to get a panel together, in a session to speak with lupus warriors, a TikTok live is simply being at your home, in your home, and we each could be a part of that panel, and we could field questions, we could give information. So once it's organized, maybe a social media arm of the Lupus Foundation, that is a powerful tool to reach and educate and inform our patients. On Instagram, TikTok, YouTube, stuff like that. Even even the courses that Dr. McNeish was saying. We could have a social media page that have, 3-minute do-it-yourself videos, how to apply Dermablend. And we have an artist come there and they put a video there, and that's not accessible for years. So I think that's one of the avenues we really should look at, and one of the ways we could better reach our patients.
Thank you, thank you. The foundation does have several counselors, right? Dr. Ho from Jam Psych. So we do have our counselors and we do have a social worker. I don't know if Ms. Campbell is here today, our social worker. But there is a support system in-house. However, that net can be spread much more widely. At this moment, I would like to close off the panel discussion with a poem from Miss Emily Elliott. And some words of encouragement.
Hello again. I just want to give a disclaimer. I am definitely not against any of the procedures Dr. Thomas would be offering to patients, because I do believe that we should be allowed to empower ourselves no matter what's happening. And I do wear makeup and I do, try to enhance things. But I had an experience, and I have had many experiences on this journey with comments that people have made. Ms. Stewart mentioned the stairs, like if stairs could heal, oh my goodness. So, but this one impacted me greatly, and usually I turn to the arts, and this time I wrote a poem about it. On this particular day, I left home thinking, why am I putting on so much makeup? Everybody knows what I look like, and they accept me, so I'm perfectly fine. I went to the supermarket, and this happened. Jesus Christ! I turned expecting to see a grown woman. Your face is so ugly. She could not have been more than 6 years old. As I stood in the supermarket aisle, stunned by the attack of this creature half my size, I boxed her innocent face in my mind. How dare she utter those words? After a breath and slightly more composed, I asked if she would wish the same to be said to her. She insisted, but it's true, your face is just so ugly. I repeated the question. She humbled herself enough to say no. I urged her to think on these things as she happily skipped away. As I fought back tears, I lamented over the encounter. That your face is so ugly made me mourn so much more than just my face. I mourned every strand of hair that I didn't ask to leave. I mourned every inch of skin that decided to scar. I mourned the vision I had of my future self when I was just her age and beyond. I mourned the greater losses endured when I felt all was coming together for my good. These teachable moments get tiresome. And it's not her fault. She lives in a society that glorifies a concept of beauty that is oft unachievable. She lives in a society where no expense is too great to get that perfect picture, to complete the perfect post, to acquire the perfect followers, which confirms her perfect life. She lives in a society that would rather laser to oblivion every blemish, chisel away every piece of unwanted fat, and remove the God-given melanin from our outer shells, whilst nourishing darkness in our hearts. She lives in a society that has to talk things them, because speech is free and we're protected behind our phone screens, the only risk of attack being verbal, and we can always just defend with words and emojis. Speech is free and compassion is too expensive and would cut into the budget that is reserved for brutal honesty at all costs, where our good deeds and selfless acts are far less significant than how we dare to leave our homes in the morning. She called on Jesus Christ, but she really has been taught to worship Instagram filters and AI. She called on Jesus Christ, but she doesn't know that Jesus' list of followers includes lepers and the lame, and the blind and the dumb, the good, the bad, and yes, the ugly. She called on Jesus Christ, but she doesn't know the purity of the love that God has for all of us, no matter what we look like, and that our job is to extend that same love to those around us. She doesn't know that all these external things will slip away, and even faster when you keep trying to fix what you think is broken, that you will leave this world with a false sense of self, only fed by the misconceptions of the misguided, the ones who do not even love themselves. I wanted to tell her she was beautiful, but I'm human too, and her words really cut deep. And while my mental attack was physical, my divinity truly wanted to say, let the beauty of Jesus be seen in me, not in a perfectly contoured face, cinched waist, toned legs, and filtered version of myself. All his wondrous compassion and purity, not in how many followers or likes or shares or videos that go viral. O thou Spirit divine, because God has ordained me as deserving of love. All my nature refine, no matter how my body has chosen to change, till the beauty and grace and peace and love of Jesus be seen and heard and felt in me and you. Thank you.
Wow. Very touching. We feel it from our core. We appreciate your expression through poetry, through music. And I hope everybody finds that certain special gift within themselves when they see our patients, to have a kinder, spirited way about them, and to really understand that lupus is not you. The disease does not define you, and that you empower yourselves by being around positivity, having a clear mind, keeping yourself healthy, and having that support group. Ladies and gentlemen, at this time, I would like to thank everyone for coming, and we will be having our We're going to be having a small token from the Lupus Foundation to our panelists. Ms. Stewart, Ms. Elliott, oh, everybody's getting one? I wasn't aware. Yes. Three. It's not working anymore? It's not.
Right. So, good afternoon again, everyone. Miss Elliott, thank you so much for sharing with us today. Right, your poem really touched my heart. I was trying to hold back the tears over there because I have to come back up here and moderate. Right, so thank you again for sharing, and I hope that you just continue to be strong, right? Because even though we were diagnosed with lupus, we were upgraded to warriors. All right.
Thank you so much.
Dr. Ho?
Dr. Ho, on behalf of the Lupus Foundation, we appreciate the time you take from your busy schedule to come and be with us and give us all the important information that we need to live by. So on behalf of the Lupus Foundation of Jamaica, I would like to give you this token. Oh, the bag.
Dr. Thomas? Thank you so much, Dr. Thomas. You've gotten your token already, but have a seat. Doctor. Thank you all. Can we have a picture? Dr. Thomas, Dr. Ho, Miss Emily, Dr. Davis, can we have a picture? Oh my gosh. I didn't know that. Thank you all. Thank you all. This has been a great symposium. At this time, I hand over to Ms. Anishka Stewart for the vote of thanks.
We're just not gonna fight with this. All right, so thank you, Dr. Lo Jones, and thank you to all our panelists. Listening to today's discussion reminded me of just how layered lupus is. It's not about just the flares or the lab results, but it's also about how we feel in our own skin, how we walk into a room and how we learn to hold our heads high, even when the world doesn't understand. As someone living with lupus, I see both sides, the struggle and the resilience. We need more workplaces to understand, more schools that show compassion, and definitely more communities that lift up instead of tear down. The work of Lupus Foundation of Jamaica is vital in not just offering support, but in changing perceptions. And here's the truth. Every one of us has a role to play in that change. So let's not just leave here today informed, let's leave inspired to act. Right? And with that said, I just want to ask everyone to also follow us on social media. We can be found on Instagram and Facebook at Lupus Foundation JA. Right? So that will also help you to keep up with the activities that are happening in Lupus Awareness Month, which is this month of October. That's why we're here today. Right? There is also, just to also say that we do still have merchandise in the back for purchase, and it would be very great if you get your t-shirts so that you can come out for Laps for Lupus next Sunday at Emancipation Park at 5 p.m. Right, so that's next Sunday at Emancipation Park at 5 p.m. So ensure that you get your t-shirts so that you can come out and support us, right? And also learn some more for persons who they probably don't have a lot of information about lupus. And, you know, as we say, most of the time, as somebody hear the word lupus, the first thing they mention is, oh, I know that somebody that will dead from this, you know, right? So we want to kind of discourage that culture and get a little bit more familiar with how you can give somebody hope, right? Because there is hope, right? So there is the QR code on the screen for you to scan it to register for Laps for Lupus. Right, we really need your support, whether you're online or here. And if you're online, you can also visit the foundation in person to purchase your t-shirt, or you can also purchase it next Sunday. Right, Kimmy? All right, great, right. All right, so on behalf of the Lupus Foundation of Jamaica, it is with a grateful heart that I extend our thanks at the close of today's symposium. Lupus and the Skin, Behind the Mask, here at UE Regional Headquarters. Today has been more than a gathering of experts and advocates. It has been a space of learning, encouragement, and connection. To our presenters, Dr. Jonathan Ho, Dr. Alicia McNeish, Dr. Romario Thomas, Dr. Lorena Muir-Green, Dr. Stacy Davis, Dr. Javilia Ho, Miss Emily Elliott, Dr. Charlene Jarrett, Miss Gaudia Chevons, we thank you generously for sharing your time, knowledge, and insights. You have helped us look behind the mask of lupus and better understand both the science and the human experience. To our moderators, Dr. Sandra McLeod, Dr. Raquel Lowe-Jones, Mrs. Yannick Sanko-Valentine, and Dr. Donna Braham, thank you for guiding us with such skill and grace. A special thank you to the LFJ team for bringing today's theme to life through video and photography. We also pause to sincerely thank our sponsors, Continental Bakery, National Health Fund, Steincares, Barita Foundation, JN Bank, Ligoni Drug and Garden Center, Wellness Health Solutions Limited, Collaborative Care Internal Medicine, iPrint Digital, Roche, Grace Kennedy, AV Concepts Limited, Realism Studios, Rheumatology Solutions, whose generosity made today possible. To all our attendees, patients, caregivers, professionals, and advocates, whether you are here in person or online, thank you for being here, for your questions, your attention, and your support. And finally, to our organizing partners and committees, volunteers, your hard work behind the scenes has been the heartbeat of this event. As we close, let us carry forward the spirit of today, breaking through the mask of lupus, deepening understanding, and standing together with knowledge, compassion, and hope. We will continue to thrive, even when sometimes our joints don't feel like it, right? And I just want to say thank you again and travel safely. We look forward to seeing you next Sunday at LAFSO Lupus. All lupus warriors, we're asking you to come to the front for a photo.
My name is Marjorie Allen, and I have lupus from about some years ago. I'm not quite sure the exact year, but it's about 20 years now. And it has been an uphill, up and down journey. Sometimes, even though it is the skin one I have, you still have the pain like what others do, and you still have the pain and the weakness and all that goes along with it.
My name is Claudette Hobbins. I am 69 years old. I've had lupus from 1982, and the journey has been up and down, as lupus is, as it affects different areas at different times. I have systemic lupus, so I have different organs affected at different times, and some a little stronger than some. Yeah, that's me.
Hi, my name is Emily Elliott. I am a Kingston-based music teacher and musician,
and I was diagnosed with lupus in April 2006. It started off with hair loss, and that has been the main issue, along with skin lesions, the scarring, throughout my journey since then. It's been a roller coaster ride, I would say. There have been some very, very severe flares where it has developed to what you see today, and then there have been some very calm moments where I'm able to just exist as normally as possible. So yeah, I give thanks that it's only my skin that it has really severely affected.
I first had a scar or a rash over my eyelid. And although I'd gone to I work with primary care, so I'd gone to many physicians there, and they're giving me steroids and so on, but nothing was really curing or stopping or preventing it. So I asked for a referral to University Hospital, the skin clinic, where by that time now I had rashes in my head, and they did a biopsy. And coming out from the biopsy, they recognized that I had systemic lupus at the time.
So when I was in university, I was in my second year of university at UMUNO, and I had locks. They were really long, like down to the middle of my back, and one fell out. I just realized that there was a space and there was no hair there. And when I touched that spot, it was very tender, and it had like a dark circle. So that was very concerning because it's something that had never happened to me before. My hair was always strong. So I went to a dermatologist, had a biopsy done, and it was immediately confirmed that I had lupus. And the dermatologist at the time kind of took it lightly and said, oh, well, it's just one spot. It's not like it's your whole head of hair. But I still had to go and see a rheumatologist and start with treatment. In about 2008, far more hair loss started to occur, where I had several patches going. I had so much hair that it wasn't that obvious. So I could always cover it up or, style a certain way that it wasn't seen. But after a while, it was really, really difficult to do that and really distressing to take a shower or wash my hair or just simply scratch my head and a lock just falls out. So that was a very, very hard time just to see all of that hair loss happening gradually. And so I decided to just cut off what was left of my locks. So I've been rocking short hair ever since.
When I went to the doctor, I discovered that I have some itching on my skin and some red bumps and so. And I was trying to ask her if she can tell me what is causing the problem, because she was giving me stuff at first that wasn't working. Anyway, she did send me to somebody who found out really what it was and start treating me for it.
That has also been a roller coaster. I mean, I can't say that I get up every morning feeling confident about how I look. I decided not to wear wigs or tie my head because it was very uncomfortable. It's too hot, and I just found myself scratching, in an effort to cover up what was happening. So over time, I mean, I don't think it took very long for me to just say, well, if people can't accept me the way I am, that's their business. It's not affecting my daily life. It's not affecting the things that I can do. And so I just had to embrace it and own it, really. And I think that has helped me to have the confidence to just wear my skin and my hair how it is currently. I do have down days. I do have days when I'm like, really, why this? Why do I have to wear makeup? Why, I have hardly any eyebrows, so I have to draw them in because of alopecia, and sometimes I feel down about that, but I try not to let those moments last too long and just accept things where they are and know that I have more to offer than just my outward appearance.
I mean, I don't feel less than anybody else. when it shows up on my skin and stuff, because I know I didn't go and get it from anywhere. So because I know I didn't get it from anywhere, I see this thing come on me just like that. I have nothing to be ashamed of.
I think my level of skin involvement is far less than many other people. So I don't really have that negative. I think it's more when I have the hair loss and